Yeah, we are. Cek, cek. Good morning, everyone. I'll give you just a moment to settle. You all good? Better let the University of Oslo take their seats.
You need to speak louder.
Can you? Okay, that's good advice. I've got to speak louder, I was told. Okay, so last day of the conference. I hope you enjoyed the gala dinner last night. Certainly the food was very lovely. For those of you that didn't stay around a little bit later, we had some more dancing. Indonesia did very well in the dancing. I think they've won the prize for dancing and badminton now, so they're doing very well. And singing, great singing. There was also a magician came along, and if you want more information about that, I think it was Edwin and Yuri that's their name, which was a bit of a joke, but yes, that was very entertaining as well. So yes, a good night. Thank you for organising. I hope you've enjoyed the first 2 days so far. There's been some very interesting topics and discussions, and we have more for you today. So this morning's session, there'll be 2 different topics. The first one's on person and case registries, and the second one's on integration. And on this first topic, on person and case registries, we've got 3 presentations this morning. One from the World Diabetes Foundation, one on stunting in Indonesia, and one on primary healthcare registry in the Maldives. So, without taking up too much time, I'll move straight on to the first presentation, which is on the Diabetes Compass Initiative. And I believe that's been implemented across 3 countries, including Sri Lanka in our region. And we're very lucky to have Martin Griffenberg here with us from the World Diabetes Foundation, and he's going to speak to us now on that initiative. So over to you, Martin. Presentations.
Can I use Yes.
Hello. Morning, everyone. Happy to be here. This is also one of those few times where I'm very happy there was no alcohol served last night. Okay. I don't want it to be too loud. So I'm going to talk to you a bit about some of the work we've done in the Diabetes Compass. It's a program funded by the World Diabetes Foundation that we've been running for the last 4 years, since 2021. Some of you may have heard about it, some of you are involved in it. But I'm going to start with a bit of context setting. So I think many of us know that NCDs are a big issue globally. But some of the numbers here, pretty staggering numbers. Today, around 600 million adults are living with diabetes, and this is predicted to go up to almost 1 billion in 2050. This is really the number you should care about. 80% of these people are living in low and middle income countries, in resource-scarce settings. Diabetes is no joke, and it is an expensive disease to treat. So where resources are limited, this becomes an even bigger problem for people. So what we do at WDF in the Digital Health Unit is we try and use digital health solutions to try and cover some of this gap, because we realized that our traditional methods were just not reaching enough people. And given the growth in numbers of people living with NCDs, we needed to do something else. So we have 3 main areas that we focus on in the Digital Health Unit, and that is advocacy, co-creation with our country partners, building hopefully sustainable digital solutions, and then partnerships with like-minded organizations such as UIO. This slide is just to say this project has a lot of partners, both technical and technology partners, but special thanks to our 3 HISP groups, or 4 HISP groups that we've worked with since 2021, Tanzania, Malawi, and Sri Lanka. two of which should be here, at least one is here, the second one not. But again, to say that there are many partners involved in this project and coordination across 3 countries and so many partners has been a big challenge for us. The project was launched in 3 countries, Tanzania, Malawi and Sri Lanka since 2021. Malawi came a bit later in 2022 through our local partners. But this is to say we started out this project with nothing but this blank sheet, diabetes care pathway, which we took into all 3 countries, knowing that there are vulnerabilities along this diabetes care pathway in even the best healthcare systems. And we wanted to see, could we use digital to try and alleviate some of these pain points along the diabetes care pathway? In all 3 countries, the pain points were roughly the same. The big issues were around early diagnosis, catching people as early as possible, because diabetes and hypertension are known as silent killers. Many people with the diseases don't even know they have them until they're seeking care, which is usually too late. So this is what we took into country. We figured out there was a couple of areas that everyone needed the support on. And then we started to co-create solutions with the governments and local implementing partners. We work across 3 different levels of government or healthcare system, the community, the facility, and the national level. There wasn't supposed to be any animations in this presentation, but so going back to that care pathway, when we look down at the bottom there, the community level, this is where government said this was the place to catch people as early as possible. So could we go out into the community and find some way of capturing those at risk? Then getting them into the facility and into care as soon as possible, and then somehow getting this data to the national level so that they were able to have some kind of idea of the burden of disease in their country and make better decisions and be able to funnel the resources towards NCD or better care for NCD patients. And then finally there was training and support of HCPs and digital tools. So the way this has kind of manifested itself in terms of solutions, in all 3 countries it kind of took a different look, but you'll see that there are some synergies or some red threads throughout all countries, and that red thread is DHIS2. But at the community level in both Sri Lanka and Malawi, they opted for a screening tool. They wanted to make the screening tool as low cost as possible, ideally integrated into something they already had. In Malawi, they already have a history of using community health workers for doing other types of work, and they had an existing system called DHIS. So they asked us if we could add a diabetes and hypertension screening workflow into that tool. In Sri Lanka, they didn't have a history of using community health workers, so we had to launch something completely new, and they opted for OpenSRP2 there. The screening tool is the same. It's a question-based screening, and it gives you a risk outcome at the end. There's no blood glucose measurements or anything taken. It's a basic blood pressure measurement, a waist circumference measurement, and then several questions that give you a risk outcome. From there, they are then referred to a facility, and then at facility level, that's where they would be diagnosed or not diagnosed. At the facility level, in all 3 countries, something has been built. Tanzania and Malawi opted for an NCD EMR module within their existing EMRs. In Sri Lanka, again, they opted for OpenSRP2 for the clinic workflows. Then there's some custom integrations. In Sri Lanka, it's a Fire-based integration, and in Malawi and Tanzania, not so much. And then at a national level, there's a DHIS2 data warehouse integrated into the national HMIS platforms in all 3 countries, and then some data visualization dashboards. Our hope has always been, and is now kind of coming to fruition, is that we could elevate some of these things from the Diabetes Compass to a kind of a global public good, if you may. And so we're working with UIO at the moment through our new project partnership to kind of elevate whichever pieces of these make sense for the global community. More practically, this is kind of what the tools look like. So we have a screening app there based on OpenSRP2 Fire, Android Fire SDK. This is the same at the facility level, so both mobile tools, and then at the national level, the dashboards. These are heavily inspired by Resolve to Save Lives, which we've worked with we've implemented a lot of the visualizations that they've used in their dashboards and put them into our own dashboards now. In Tanzania, again missing the community aspect, but we have an EMR module based on a PC at facility level, and then we have the dashboards and the data warehouse. And this is both case-based and aggregate data. In Malawi, similar to Sri Lanka, you've got your community tool, you've got a PC-based EMR module for the clinical care pathways, and then we've got our data visualizations. Yeah. So, what's next for us? We continue to work with the ministries of health in each of these countries, as well as our technical partners. We have been asked recently in Sri Lanka if we can extend these workflows past diabetes and hypertension, which makes sense because we talk a lot about de-verticalization, and here we were in a vertical. So we're looking at the option now to extend that and also to provide more value to the country for them to be able to scale this beyond the pilot facilities. In Tanzania and Malawi, the systems naturally were already extended to other NCDs. And that was, I mean, by default, but also by request of the government. They didn't want systems just for diabetes and hypertension. At the same time, there's an impact evaluation research component ongoing, which I believe will end at the end of next year, and that research will be made available to everyone. A partnership with UIO that has been recently launched to strengthen the NCD toolkit that has already been established. There's also some capacity building components in there, so we're really excited about that partnership. And then we continue to do the work we normally do with governments and implementation partners in other countries that need support around NCD, digital health strengthening. And then coming to a venue like this, supporting knowledge sharing. So I could go on for many hours about the challenges we've encountered along the way and continue to encounter along the way, but I wanted to just discuss maybe 5 of them. So one of the biggest challenges from the onset has been setting realistic timelines. We, as donors, have fairly strict timelines where money needs to be spent, and governments often agree to those timelines, but then when it comes to the actual implementation, we go over constantly, and that's due to no one's fault. There's constant changes of politicians, there's a lot of different disease verticals that need to be covered, and we're working in resource-scarce societies. But this does create a lot of tension, and it's one of the ongoing battles we constantly fight. And then intergovernmental department alignment. This is something that we face daily. In some cases, the NCD units have never worked with the Department of Health Information, so we're the first ones to introduce them, and these things just take time. Fragmentation, this is something everyone knows about. We want to break down the silos, as everyone says, but in reality, this is a lot more complex than meets the eye. It's not just about meetings in Geneva and New York and Oslo. There's a lot more to it. And I think it just requires a lot of governance and kind of strong leadership to be able to work towards breaking down these barriers or silos. Another thing that I personally have overlooked, change management of the implementation of new systems, especially going from paper-based to digital systems. This continues to be a challenge for me. And the resources needed to do this are different, country by country, case by case, facility by facility, but it's something that really needs to be taken into account from day one, and you need to plan a lot of time and resources for that. And then possibly my favorite one is too much focus on the shiny things. I think I've just had a discussion this morning about AI-based tools. In many of the countries we go to, everyone is demanding these fancy things. They want AI this, AI that, but they haven't got the basics right. And I think until you get these foundational tools working and good quality data from the basics, these shiny things are just adding complexity to systems that don't work. Yeah. So if you'd like to know anything more about our project, you can go to these websites and contact me directly if there's anything more you would like to know. And that is the end of the presentation.
Thank you. That was very informative. Had some good lessons at the end that I'd agree with, and I think I saw a lot of heads nodding. We've probably got time for one or two questions if someone has a question. Oh yes, up the back, yes.
Yes. First of all, thank you so much for the presentation. I think this is great efforts regarding diabetes and other NCDs. Just a quick question: to what level the data analysis done? Just to measure the prevalence, the correlation between risk factors and diabetes, the mortality rate, or exceeding to the relationship between socio-economic, because this done in 3 countries, in different countries in different locations. So did we measure the impact of socio-economic on diabetes to measure the ecosystem, how play a role in this NCDs? And thank you.
So we are not doing that, but theoretically it's possible. At least in Tanzania and Malawi, that data is captured, but we're not doing that kind of analysis on socioeconomics. But I know for a fact that it is captured in the EMR system in Tanzania and Malawi. So if there was a desire by the government to do that kind of analysis, it would probably be very possible. And I don't know, Sri Lanka, you're not capturing that?
Yeah, this is a very good question because we get asked about this in many other projects as well. So not at the moment in our health sector digital systems, but this is a data that is readily available because we have, of course we have the census, but in addition there are like other ministries who are regularly collecting this information. So it's available, but it's a good suggestion. Yeah.
One more question. So in Bangladesh, we have, we know that we implementing simple app for hypertension and both diabetes mellitus. So the one major challenge for expanding that, because we initially asked to implement it through DHIS2, which will be more faster. But the challenge we found that there's only this tools specifically dependence on 2 more ingredients. So one is the equipments, so hypertension measurement equipment, and also the diabetes measurement equipments, and who will supply that. So for simple, they are supplying that. And earlier our projects, in government projects, they supplied the diabetes tools, but that's not working anymore. Same for the hypertension measurement tools as well. So in this project, your specific project, we are interested to join in, but you should consider those types of issues, plus the controlling. So hypertension control, the government wants to make the control also track from there. So we are doing the hypertension and diabetes mellitus control rate and other things. So denominator is important, also the numerator. So what actually their government doing, they are dispensing the drugs. So for hypertension, they also amlodipine and other first line of drugs, and for the diabetes, they also metformin or this kind of drugs they are also distributing. So are you doing this kind of anything, or just only technical implementation?
So we do not fund drugs. It's in our mandate not to fund drugs. So that answers that one. With regards to blood pressure measurement, we are supplying the machines at the moment. It's actually a machine that was suggested to us by Resolve. It's a low-cost blood pressure measurement device. We're yet to see if governments can absorb the cost of this after the program. Diabetes, blood glucose measurement, through our traditional projects, WDF standard projects, we normally supply that kind of equipment, but in the digital component or the digital team, we haven't actually supplied any of that. So we're relying on governments to kind of supply that, and that's purely for sustainability reasons, because many countries, as soon as the project dies, they stop funding the glucose strips, and then you have no data.
Okay, we've got quite a few presentations this morning, so we'll move on. Another round of applause. Thanks. Thanks. Cheers. So next we've got Dr. Very, who is presenting on stunting, the work they're doing around stunting in Indonesia, specifically in Jakarta. You okay? Yeah. Did you want the pointer?
Hello everyone, good morning. Well, this is my first time attending DHIS2 event. So honestly, I'm very amazed with this event because it's truly inspiring, where I can see many countries sharing their success story and their tools, so other country can adopt and can modify the tools to adapt with their own condition. So thank you for DHIS2 for inviting us to come and give us a chance to share some of the tools that we already implement. Yesterday, Dr. Intan already shared about our implementation regarding the climate change with the health data. And today I'm going to share one of our tools to monitor the intervention for malnutrition, specifically for stunting. Okay. As you know that Jakarta is quite a big country with big population and also with many health facilities. But all of these big things, of course, not only become our strength, but also become one of our weaknesses. Jakarta, as the Indonesian capital, has many complex health problems, especially when we talk about health information. There are a big homeworks for us to integrate many of our health facilities, which maybe not all is government owned, but many as private. So Jakarta, even though maybe you know that Jakarta is a big city, a megapolitan, but we still facing problem regarding malnutrition. Jakarta has recorded 17.3% prevalence of stunting, although it's already decreasing in 2023, but still higher than 2022. So overcome stunting is still one of our biggest concern in Jakarta. That is why we in Data and Information Center Unit for the Public Health Office start using DHIS2 to help us to overcome for the reporting, recording, and monitoring the program. In Jakarta, stunting must be diagnosed by the pediatrician. So the primary health care can only diagnose the toddlers as malnutrition. For the definitive diagnosis, the toddlers must be referred to the hospital, and then the pediatrician will give the definitive diagnosis. Then for the stunting itself, the toddlers will get a special therapeutical food and that is only can be prescribed by the pediatrician. So in this journey, the patient will come to the primary health care and then refer to the hospital, and in hospital they will get some laboratorium tests and so on. So we have to integrate all the data from the primary health care to the hospital and also for the laboratory system. So we need the system to record and track all this journey of the patient. That is why we choose DHIS2 as our tools. So this is the business process for doing the the DHIS2. You can see it here. I only gonna talk about the implementation because I believe you're already expert with all these things. So right now, all of us, whether it's the physician in the primary health care, whether it's the physician in the hospital, or our leaders in the provincial health office, also the governor now can see the dashboard, and they will know how many babies in Jakarta that is malnutrition, and how many from the malnutrition that is has the definitive diagnosis as stunting, and what have we done to them? Did we already treat them according to the guidance or not? And how many of them already get the food therapeutic medical things? So we can show them the dashboard to all the leaders and all the stakeholders. And because we have this kind of system, we can also be responsible with all the tools, with all the asset that we already use. So when we get audit and so on, we can use this system as the evidence to support our health service that we already did. Okay, so the challenge from these implementations are we still have notifications and of high risk of treatment failure or loss to follow up. We still try to analyze the data and find the root cause, but mostly because, in Jakarta, although we have so many health facilities, but this program only can only provided in general hospital, which is owned by the government, and sometimes the citizens is not willing to come to the general hospital because maybe they think it's very far from their house and so on. So we are hoping to replicate this system not only in the general hospital but also in hospital in Jakarta, so we can give more access to all the citizens. Also, we would like to develop more interactive dashboard mapping, stunting, and so on. And we are trying to collaborate with more and more relevant agencies. So I'm really interested with some of the tools that our colleague from other countries already present from these days. So yeah, I'm willing to collaborate with all of you, so we can perfect these tools, and also hopefully that the tools can also be have a good impact in Jakarta and maybe in other countries. I guess that's all from us. hopefully what we have shared today can also get benefit from all of you. Thank you so much.
Well, thank you very much. That was really informative. We've got time for questions again, so do we have any questions from the audience? On stunting, you might get away without any questions. You might be lucky. No questions? Okay, well, thank you very much. Another round of applause. That was great. Okay, on this topic on person case registries, the last presentation will be from the Maldives on their primary healthcare registry. So we've got Priyanka from HISP Sri Lanka is going to present along with Dr. Mamino, the DDG from the Ministry of Health. Momina, sorry. You're right. You've got that. I think the clip is up there.
Yeah. Good morning, everyone. I'm presenting the DHIS2 the technical part, and the DDG Mumina will present the implementation and the public portal part. Right. So this is about primary healthcare registry in Maldives, a DHIS2 module to capture individual data. Primary healthcare registry is a DHIS2 based software to manage individual level information of non-communicable diseases in primary healthcare settings in Maldives. So we all know the NCD is a world epidemic, rather a pandemic. Community level interventions together with individual interventions are the key to manage. So early detection, early treatment and prevention are the key to success of managing NCDs. So proper information management is a must. So when creating or when preparing the primary healthcare registry, so these are the guidance documents we used. So this is basically based on WHO PEN package, that is WHO package of essential non-communicable disease interventions. And also we incorporated HEART's technical package to calculate CVD risk. And also the introduction of a mental health component into primary health care, again by WHO, for the screening purposes of mental health illnesses. So these are the charts we in the HEART's technical package we use to calculate CVD risk. So we use, based on these charts, we are using program rules to calculate CVD risk. I will show. Basically, three main functions: to collect, store individual data and provide vertical patient record, and to analyze data. The PHC registry will provide all these three functions. If I talk about special features of primary healthcare module, this is full compliant with WHO PEN package, and CVD risk score is auto-generated based on the data entered according to the HEART's technical package. And also this is included two mental health components. One is PHQ4, mini mental health screening package, as well as mental health assessment. And the system is also compatible with CHEART's indicators. You may be aware of the CHEART's indicators, which has been put up by the CRO with regard to NCD monitoring. And dashboards are available for all levels from island to the national. And separate dashboards are available to monitor the disease level, disease condition, disease status, as well as the process monitoring. So that is one of the key features of this system. So we have a special dashboard for process monitoring. And the design is intervention oriented, and also we have generated intervention oriented line list, and easily scalable and customizable. And not only this DHIS2 customization, PHC registry comes with the entire package of implementation together with user guides and user manuals. Data is captured in 3 steps. First step is empanelment or registration, that is enrollment, and 2 program stages, initial assessment and follow-up. So this is how it was implemented. Empanelment was done as home visits or in campaign mode. Then the initial assessment and follow-up was done through the health centers. This is an overview of the attributes and data elements we are using. I have just mentioned the areas. So in empanelment, basic demographic areas we captured. And in the initial assessment, history of past NCDs, treatment history, family history, and risk factor assessment. As I mentioned, mental health assessment, and mental health screening as well, examination, investigation, diagnosis, and also referrals. And in the follow-up, we are capturing risk factor assessment, again we are repeating, and mental health screening and assessment, again we are repeating because they are very dynamic. Treatment assessment, then examination, investigation, diagnosis, and also complications and referrals. So this is the individual level or the tracker dashboard. So you can clearly see the 4th indicator, CVD risk. So that is the CVD risk score, which is generated through program rules based on the HEARTS technical package, WHO. And NCD risk score, that is a country specific risk score based on the risk factors. So that is also generated. And you can see PHQ-4 score, and also BMI and BMI category, and even ideal body weight. So to generate CVD risk calculation, this is for DHIS2 implementers. So we use so complicated and very long program rules. This is only a part maybe of the program rule. And we have a comprehensive set of dashboards. So this is the aggregated dashboard for process monitoring. So this will show the entire population of that specific island and how the percentage of empanelment and percentage of initial assessment and follow-up information as well. So just by looking this, the health authorities can have idea of how the process is going on. I'm not about anything about disease, but the process, implementation. So this is one of the disease dashboard. This is hypertension dashboard. In this hypertension dashboard, again you can see the percentages of hypertension and percentage of hypertension patient with controlled with drugs and not controlled with drugs, and even not on drug. So this is a disease dashboard, and there are multiple links to line list which will show who are not on treatment and who are on treatment and not in control. So that will help in managing patients for the improving the disease status. Same type of dashboards are available for all the the NCDs, diabetes, cardiovascular diseases, and so on. And also we have a separate dashboard for CHEARTS indicator. So this is a reporting requirement from ZERO. So they have defined a special set of dashboards for reporting NCDs in ZERO region. And the system comprises of a comprehensive set of user support documents, including user guide, very comprehensive user and implementation guide, and also these one-page guides. You know, Maldives is a island nation, so it's very difficult to reach each and every user and reach each and every island for this training and user support. So we have to find different modalities and strategies for that. So this is one strategy. So these single page guides per main action, we have just one page guide which is very illustrated without lot of text. In simple steps, we have mentioned, okay, what to do, 1, 2, 3, 4. The users can follow this, and so we have tested and proven this model is very effective in terms of user training. And also these compile guides to show the workflow, and this is basically a PDF file. If you click on one of these steps, it will guide you to the relevant one-page guide. So that's my part. So now I would like to invite DG Mumina to continue the implementation and the public portal part. Thank you very much.
Good morning. Okay, now I just will be continuing from what Dr. Priyanka has just explained. Now, what happens to all the data that from the PHC module that is being entered into the portal? So, what happens? We, as a ministry level, the policy level, we all could see what is happening. We could plan for our resources, but what happens to the public? So we introduced in December 2024 a way for the public to view the screen data. So that is called MIHIS, MOLIS Integrated Health Information System. So this portal was introduced in December 2024 where the public, the citizens can view their data, how many times has been screened and how many days is for the next screening day. Examination, diagnosis. So this was one of the very successful launch that we did, and public also has accepted, and they are working. We are trying to include other modules also to this, where, for example, we are planning to, if in future, for the electronic health medical record we are planning on that. So next step would be for them to view their data, citizens to view their data through this portal. Okay, now we did have a lot of lot of benefits. One was we were able to detect the NCD early detection coverage. And also risk target prevention, so like for tobacco and reconnect and salt and obesity, targeted groups we were able to identify. And also one more benefit was that the continuity of care and better outcomes we were able to identify, and then so we were able to resource smarter allocation in resource-wise. We were able to identify which island needed more doctors, which island needed more nurses to fully, successfully implement the PHC module. And we were able to data-driven policy making. For example, through this module, we were able to implement additional 2 dialysis services to 2 different atolls. Now, with the benefits, we did find some of the challenges, like for the workforce and workflow capacity. So in the initial screening, we found that we did need a lot of workforce capacity, because our target was to screen the whole population of the island from 18 years and above. So we found that, okay, we needed more doctors, and we need, but however, we were trying to, during the training also, we were trying to encourage to use the, for holistically think and use the whole healthcare professionals in that community, in that healthcare facility. Doctors and nurses and also primary healthcare workers were encouraged to be utilized in the program. And also, successfully, we were able to include PHC module in their job description of the healthcare workers. So they know that in their job description is include. They know that okay, PHC module is something that they have to do it in their job. Okay, now another challenge was that the interoperability. We know that okay, the healthcare facilities, if they are to be referred to another healthcare facility, the data we were having problems on that area. However, with the we are planning to implement more digital health blueprint very soon, and under the MOLDIS 2.0 digital transformation, we plan to tackle that problem. So we hope that health information exchange will happen seamlessly. And also gaps in the resource such as essential NCD medicines create bottlenecks. So we are trying to tackle to that problem also. Another challenge is that it takes time to make changes to some of the high-risk groups. We need still encourage those population groups. Looking ahead, we have remaining a few more atolls to conduct the training. So we are trying to finish the remaining trainings and atolls and also strengthen the supervision and implementation standards, standardized SOPs. And also with the data quality and interoperability, as I mentioned before, we plan to tackle that problem of interoperability with the MOLDIS 2.0 transformation and digital health blueprint. Once it is implemented, we hope to tackle that. And also expand the portal with other tools such as nudges, multilingual, and support the follow-ups. And another area that we will be focusing is that we will be adding KPIs and track the KPIs and then for better policy actions. That's it. Thank you.
Thank you very much. Very informative. I'm always impressed with when I come to these conferences with the Maldives and the work that HISP Sri Lanka does to support. I work in the Pacific with small island countries and a lot of similar challenges, but some of the things that the Maldives are doing is really impressive. And I particularly like this one because I mean, NCDs, NCD Pen, it's a challenge to roll out and have everyone making the right decisions, doing the right interpretations, and to see that in DHIS2. I know in some Pacific Island countries they've looked at heart care and different sort of applications, but to see it rolled out in DHIS2, that's really interesting for me. So I'm hoping there's some questions because I thought that was very informative. Everyone, maybe it's Friday morning and everyone a bit tired. Yes, down the back. Do you want to go up to the microphone there?
So, thank you for that interesting presentation. I have a couple of questions. One is a little technical regarding the public access portal, because a lot of countries are now planning to have these e-health records and access. So how did you manage this access control? Does Maldives have the DPIs for that? Or I know there's a citizen portal, but how was it managed? That's one question. And the other one is about the implementation. So there'll be a lot of other facilities also coming into the picture, like laboratories and maybe pharmacies and everything. So how do you link, what's the plan to scale up the primary health care record to link with these expansions? Thank you.
Okay, thank you very much for the question regarding the integration. So at the moment, the system is not integrated with any of the laboratories or the hospital information systems, but it is on the way. So as DG Mumina mentioned, so we are in a process of integration. Maldives is still in the late phase of developing their digital health architectural blueprint. As a part of the blueprint, the health interoperability layer will be implemented and FHIR is identified as the interoperability standard, and with that the integration will be established. At the moment, no integration. And to access the public health portal, now we are using, you can, yeah.
So, yes, so there is an e-FAS for the government established e-FAS where they have to use the unique health ID, unique ID, their IDs. So through the ID from the e-FAS portal, it has already been, so they can use that login.
Any other questions? You sat back, go on.
Question, since we had this diabetes compass in the morning, and that's okay, now it's Maldives, but Sri Lanka is a common denominator here. So how much of the, I mean, and also in the first presentation it was talking about breaking down the silos and stuff like that. So how much is floating between this project, and this is also quite similar to the diabetes program. So how much is floating of knowledge and shared tools and stuff between the two initiatives?
Maybe I will take that question because I am the common denominator. Yes. All right. Anyway, so it's a very interesting question. I would say addressing the same issue, but two different approaches. So in Sri Lanka, technology-wise, it's a different approach. So the main difference between the two implementations is rather the technology. But when it comes to the Maldives implementation, the other thing, I will come back to technology very briefly, but the other thing is about like who's implementing, and then again like what kind of indicators that we are looking at. So it's heavily like depending on the indicators, as Priyanka highlighted, heavily influenced by WHO guidelines and indicators. Whereas when it comes to the diabetes compass, it again had a lot of, I think, stakeholder discussions, Martin, right, which also includes WHO indicators, but there was like a lot of local indicators and cross-country discussions that also feeds into what we monitor. So that's one difference when it comes to the NCD technical side. Technology-wise, Sri Lanka, it was more about FHIR. So the interoperability using FHIR standards, depending on the blueprint implementation, was very central. So that's why, for example, OpenSRP is there. But then the similarity is, finally, when it comes to visualizations, it's DHIS2 which is being used. So the visualizations, monitoring indicators, the platform we are using is DHIS2, but the capture is different. Whereas Sri Lanka, it's OpenSRP, and the data exchange is using FHIR. But in Maldives at the moment, DHIS2 is heavily used for all the individual level public health program data collection, other than the EMR, the medical records data. So that way, it's still very uniform because it's a matter of just integrating with the FHIR server. So I perceive it to be a very smooth integration that way, whereas in Sri Lanka, it's going to be quite complicated because so many different systems are involved. Yeah.
Did you have anything else? Did you want to say anything on that, or no? Okay, we've got time for one more question if there was one, otherwise we can move on. No more questions? Okay, well, thank you. I think those three sessions have been really interesting. I think a round of applause, please. Three very big topics, of course, diabetes, stunting, particularly stunting in Indonesia, which is a big problem, and then, of course, NCDs. So very informative. I think all the discussion around integration is a good segue, because the next, we're going to move on to integration now and FHIR implementations. What did we decide, Pamela, in terms of who's going first? We're going to start with Taufik. Sri Lanka first. Yes. So we're going to hear from Sri Lanka first on their FHIR DHIS2 implementation, if that's okay, Priyanka, and then we'll have Priyanka will speak and just introduce, and then we're going to have someone join us online, Hazli Mohammed, to present. So are you right to go? Okay, good one.
Welcome again. I am on a different topic now. All right. DHIS2 fire integration use cases from Sri Lanka. So I am not going to do kind of a technical presentation. Our senior developer, Hazli, will be doing a detailed technical presentation. My task is just to give some overall idea or an introduction, because I understand that there's a very diverse group of participation here. You may be very familiar with fire, or you may not be even heard of fire. So that's why I'm having these very few slides. HL7 fire. Fire is all about health data interoperability. If you know what is interoperability, that's fine. If you don't know what is interoperability, interoperability is effective communication between systems in a meaningful way. So we know there may be multiple systems in a country where data is captured from same individual. For an instance, say just consider a newborn, may be registered in CRVS, then go to the immunization registry, may be based on DHIS2, and if get some illness, go to a hospital, then the child will be in EMR of hospital A, in hospital B, and so on. And if get some communicable diseases or something in disease registries. So even though there are multiple systems, it is only one individual. So always it is beneficial to know what other systems know about that person to a system. So for that, we need to implement this interoperability, basically talking between systems. This is not that simple and easy, because each of these systems are using different technologies. It's like all of us. So we natively use different languages to communicate, but here in this conference we are using English to communicate because it is the language we all can understand. So fire is the common language to talk between systems. Fire is a standard to pass information between systems. Then I am presenting this Sri Lanka Digital Health Blueprint. In this Sri Lanka published this Digital Health Blueprint, and in the process of implementation, right? Sri Lanka Digital Health Blueprint emphasizes that interoperability of systems and information sharing is key to success of the national digital health ecosystem. And also it underlines that systems must be interoperable via common standards and architectures. The common standard we are using to talk between systems or interoperability is FHIR. It explicitly encourages alignment with global standards such as OpenHIE and FHIR as interoperability enables. The blueprint supports using FHIR-based exchanges in its vision for the National Health Information Exchange. So this is the background. On this background, there are two main use cases in Sri Lanka. Basically, DHIS2 Sri Lanka involved. Actually, this is the only practical example at the moment available in Sri Lanka, on which our senior developer Hazli will be presenting in a more detailed manner. So now I invite Mr. Hazli to join online to present the technical part of that. Thank you very much.
Yes. Hazli, can you hear us? We can't hear you, if you can hear us.
Hello, can you hear me?
Yes, we can hear you now. Can you hear us okay?
Yeah, I can hear you well.
Okay, great.
By the way, can you see my screen as well?
Not yet. We'll just give it a moment. Have you shared your screen?
Yes.
Okay, all right, it's come up now. Okay.
Visible?
Yes, we can see you. So over to you.
Yeah. Okay, thank you so much, Dr. Priyanka, for that precise introduction to FIRE. So, hi everyone, I am Hasli Mohammed from Senior Software Developer from HISP Sri Lanka. So, since a basic introduction is being given to FIRE by Dr. Priyanka, I will start my presentation with the question, why FIRE? So, as you may know, many systems nowadays, whether it's a healthcare system or maybe a non-healthcare system, all they have APIs. Often these APIs may be REST-based APIs, well documented. Sometimes they may use some Swagger or Open API to publish their API endpoints as well. And using those APIs, of course, you can read and write data to the systems. If we closely look at two different systems, for an example, I have given two different systems here, which is basically throwing two different API endpoints. The first one is, let's say, a system A, some random system, and then we have a DHIS2 system, right? So now if you look at, we are fetching this data through the endpoint which is given below, and system A returns us this JSON formatted resource, and DHIS2 returns this formatted resource back to us. Fundamentally, these are representing the same patient information, but on its own API responses when we try to fetch the resource from these different systems. Let's assume you are being equipped with a task to integrate these two systems where it should talk either way. Either system A talks with DHIS2 or DHIS2 talk with system A. Then you will always get started to work with writing a custom data mapping for these two systems to talk with each other, right? Suppose let's assume that either system A or the DHIS2 side, if it is system A, let's say the system A changes their field names, or maybe DHIS2 which changes the attribute IDs, let's assume. Then in such cases, what happens? Your entire mapping will be lost and your integration will no longer work, right? The reason why it's not happening in that way is, number one reason is, the main reason is being that there is no shared understanding. In this case, each system does not know what's actually patient means and how they are exchanging the data. Let's dig a bit deeper and look in a way how FIRE plays a critical role, right? So if we think your both systems can speak the same language, which is FIRE, then from both the sides, any request you send will be accepted as it is, right? For an example, either from DHIS2 to system A, you can simply say, get me all the patients with this ID, and it will return any patient who matches with that ID. Or I can fetch, okay, give me these patients whose name matches with this particular name, something like that. And the same query can be executed by system A to DHIS2, and the DHIS2 should be able to return those responses as well. So as a result of this introduction of FIRE in the middle, there are no custom transformation is needed because both the systems knows what a patient resource means and what is the format it's trying to communicate with. And also it ensures the reusability, because once you get this thing done on one end of your system, then integrating with any future requirements, for example, let's say in future you want to integrate with a different system, it's very easy. You just need to plug it in and the system will work without any huge effort. So basically this FIRE stands for Fast Healthcare Interoperability Resources, is more than just an API. It's a global healthcare data exchange. It's a standard for global healthcare data exchange. And I have summarized few things. So basically it defines kind of a data model. So meaning these are defined as FHIR resources. For an example, like patients, observations, encounters, and so on and so forth. And each of these resources has a clear either JSON or XML format or schemas, in other words, and the semantics. So anybody, by looking at a specific resource, they can say, okay, this is the format, how this resource should be formatted in. This always follows a standard uniform RESTful API, like what we saw before. You can just throw a query and the responses will be always returned if the endpoint supports FHIR endpoint. So in a nutshell, in simplified terms, we can say, if you are calling a patient resource from any system, it can be HappyFire, maybe Google Cloud Healthcare API or Microsoft Cloud Health API, it doesn't actually matter where you are querying, but the query will always run as you intended. So furthermore, FHIR also already has some built-in healthcare specific features, something like versioning endpoint. So every endpoint, for example, if you take a specific patient, an instance of that, let's say a patient A, then any changes you do to that patient A will be versioned and maintained throughout. So this will ease your process of auditing and provenance. And also it allows you to have some terminology bindings, for example, like observations like hypertension or diabetes. In such cases, you can tag SNOMED, LOING, ICD codes. Then it also has some inbuilt support for security profiles like OAuth or Smart on FHIR, validation and confirmation checking, which I personally think which is very crucial for healthcare systems, specifically for auditing and make sure that the system is up to a certain level of acceptance. And the FHIR is built by HL7. Though now it's widely adopted by multiple different organizations like WHO, Ministry of Health in different countries, and different EHR vendors also now adopting FHIR as a standard for interoperability. So when we talk about the Ministry of Health Sri Lanka also adopted FHIR as a standard for data exchange in the National Digital Health Blueprint. And this is the point where it's getting much interesting. Because if you
I'll just interrupt just briefly. We might not have been able to communicate, but you've probably only got about 5 minutes, just so you're aware, that's all, because we saw you got quite a lot of slides. So yeah, just to give you a heads up. Thanks.
Sure. Right. So here we can see this is the architecture for this National Health Digital Blueprint. And here the main component which I would like to highlight is the NEHR repository, which is over here, right? So this is the repository where you have to exchange the patient health data to. So the reason why we are talking about the FHIR and all these exchanges because Sri Lanka adopted FHIR standard for their NEHR, and any data that you gather from any system needs to be pushed to this FHIR server. So there are many, in order to enable this integration happen, we need to have some kind of guide which tells us how we need to integrate. So the first one is the primary task is to generate an IG implementation guide. So this is an implementation guide for Sri Lanka. I have provided the links and all, maybe you can just even Google and you can find it out. And based on this, there are two projects which is notably in line with this architecture. The first one is the Diabetes Compass project. So the main objective of the project is to enable early detection of clients who are high risk for hypertension or diabetes at the community level. Since there are different technologies involved in this project, for collecting the data at the community level, we are using OpenSRP2, and the data will be pushed to DHIS2 for further analysis and visualization. And we also push to NEHR file server, which is the national repository, to store the historical patient information there. And this is the brief architecture, how everything's are working together. And the second project, specifically we are talking about DHIS2 MOSIP integration. So the main use case here is the antenatal care, where we specifically having an integration with DHIS2 and MOSIP. So DHIS2, we have a capture plugin, which basically communicates with MOSIP to verify a pregnant mother with their NIC to make sure that the person who identifies themselves is true or false. And their information, demographic information, will be pre-filled onto this DHIS2 form. And also we have another capture plugin to verify the personal health number if the patient already has one. And this verification of this personal health number actually queries the National Electronic Health Registry to make sure that's a valid personal health number and that actually the person who claims is the actual one, right? And also by looking at here, you can see there is 2 more other integrations coming with, which is a clinician portal, which allows gynecologists to check the patient past medical histories, and also a client portal where the patient should be able to log in themselves and they should be able to get their information seen. So now based on this architecture, you can see everything, the clinician portal and the patient portal, both are connected to an NEHR, which is actually a file server which stores this information. So for this end-to-end solution, it will not be a very easy implementation if we don't have this file integration with the National Electronic Health Registry. I think with that, that my presentation ends.
Thank you so much for joining online. That was really useful for everyone. And sorry I'm hurrying you along. We're always on a tight time schedule. Do you mind staying online just for perhaps another 15 minutes in case there's some questions at the end? We might leave some questions until the end and get moving with Indonesia's presentation. But that was really informative for a lot of people in the room here. Next, I'm going to get to the floor, Taufik Sitampul. I'm never sure if I say the names right, I'm sorry. But going to speak on the Indonesia experience. Yes,
Yeah.
So over to you.
Thank you. Good morning, everyone. I want to share about the FHIR implementation, especially from National Health Information Exchange in 1 Sehat. And this is too, especially for our subnational levels programs. Next. Oh, yeah, sorry. Yeah. The context of Indonesia is based on the demography and decentralization. It means we have 38 provinces, more than 500 districts. Decentralization of the health system, it's very, very crucial how we embed interoperability here. And since 2022, we have the National Health Information Exchange using FHIR. We already implement based on the digital blueprint version 1, 2022 until 2034, and we currently moving from version 1 to version 2. You can see the idea how we develop of the interoperability from the existing legacy standardization moving to the 1 Sehat standardization. This is our artifact here. So the next here, why we are moving from the interoperability, because of the interventions from the expectation from Ministry of Health and collaboration with another program previously with USAID project here. So our implementations currently from Ministry of Health, national levels, Jakarta, with Dr. Ferry area and East Java province. How we build the National Health Information System Exchange? We start with the initiation of the architecture. Previously, we hope is very, very easy to replicate. Previously, we utilized from the OpenHIM product as the global standard, global digital public good as well. So that's why we can initiate from the non-FHIR implementation at facility level and with FHIR expectation. So this is the area what we can see of the implementation. And the context of the interoperability, we standardize based on the use case and also from the registry itself. For example, national registry, 100% of the individual data currently connected to the Satu Sehat, and also facility registry, health worker registry is embedded to the Satu Sehat itself. So this is the expectation how to share the information to each other. So it's very, very crucial. We can say if we were to build regional and share record, how we would actually use the data. Because we collect the data, we share the data, but how to use data, this is very important to respond from Dr. Ferry or East Java presentation previously, for example. Next. So the piloting version 1, we escalate from the initial to the Jakarta and also East Java. Why? Because East Java and Jakarta, they have the strong foundation of the implementation. Local politics is stable, institution is more very important, standardization, EHR is also very important with them area as well. And a lot of mention, this is the Java center of the implementations. And next. So the more architecture we converted from the version 1 to version 2 is because of the ability FHIR itself and also the compatibility of the DHIS2. For example here, version 1 we export from FHIR to SQL data mart. This is more technical, and we use DHIS2 as the data visualization and superset. It's the Apache product of open source as well. The version 2 we migrate. We use why? Because of the objective of the technical is very important. For example, how to make a stream data between facility to centralize, or how we embed the supersets for proper way. Next. So I want to mention here in East Java, very, very difficult to mention about DHIS2. So this developer prefer to use superset to visualize data. Why? Because DHIS2 is inherent complexity of FHIR data to effort require translate FHIR to SQL, and also the lack of understanding of data DHIS2 model itself. So this is our effort, how to strengthen not only from technology but the capacity itself. Maybe next session is from our technical team, Diana. Next.
Okay, so yeah, my name is Diana. So before we move to the technical aspect, I want to state a few things first. So thank you, Sri Lanka, for introducing FHIR to everyone. And the second is that some of you might be wondering, why is Indonesia doing it differently? Why don't we input our data to the DHIS2? Because the DHIS2 support individual data, right? So the question, the answer was that before the DHIS2 is introduced in Indonesia around in 2018, we have already a few routine health information systems using individual data for TB, HIV, for maternal death, and before that, even that, we already have established electronic medical record systems running in the hospital, hundreds of hospitals and puskesmas. That's why we already have our own running legacy systems before the DHIS2 was introduced. And the idea is that all of the routine health information systems data that are used by the Ministry of Health, that in some countries is using the DHIS2, and in our country is developed in-house in the Ministry of Health. We can take the data from electronic health record, because most of the running electronic health record in our country has like around 60 to 70% of similarity of data to what is required in the national health system. So the idea is to move what we have in electronic health record using FHIR, and then we move that to the whatever it is used by the Ministry of Health for program monitoring, surveillance, etc. So that's why we are using different approach here, and it's going to be quite technical from here. So I think Sri Lanka also explained that they use a viral fixed, so converting the hospital's data or other API data to FHIR. So we use that as well. And then from that, Sri Lanka also use like a data warehouse where they stored the converted FHIR data into SQL data because our database uses SQL. So that's a complex process in itself. So this is just the illustration that if you're familiar with the FHIR resources, the data is very granular. What was shown earlier was a very, very simple example of 10 lines API, but actual data can get to thousands of API just to describe one single patient. So it's very complex, it's very granular, so we have to move that to the SQL, but we acknowledge that this process is not very efficient. And globally, it is also acknowledged that this process is not efficient as well. It's not only complex, but it also increases the possibility of loss of the data because of the different data models, etc. This is example. So after we have the data warehouse, we have the smaller tables that we call data marts. So these are essentially the data that are ready to use to our HMIS. It can be superset, it can be the DHIS2 or whatever that we choose in our country. So this is example of patient data from FHIR. This is simplified version from the actual API in the FHIR. So the hardest part is mapping from the individual transactional data that is in the FHIR resources into the data model in the DHIS2, and not to include the complexity in the SQL as well. So for example here, we tried to map the FHIR, some of the FHIR resources, if you ever heard of encounter, condition, basically saying about the diagnosis of the patient, when did the patient come, etc. So we map that to data elements. And each data elements will have its own options. So for example here, encounter class, the type of how the patient come. Is it ambulatory? Is it emergency? Did he come from the emergency department or did he come from the outside patient, etc. So we want to capture that. So these are examples of some of the options provided by HL7 standard. And then we have ICD-10. ICD-10, if you want to use the full granular ICD-10, then there will be around 80,000 options. While it is possible to import all of that option using very simple Python script, for example, but how to maintain that? How do we maintain that inside of the DHIS2? So that was our question, especially we know that some of our characteristics multiples, for example, are moving, is moving to ICD-11. Next. Okay, so this is the example. And the nature of our program monitoring is very complex. So the number of infants born to mother with hepatitis B who are tested for hepatitis B. So you can imagine how many records that we need for FHIR to convert that to the DHIS2. And then lastly, so we are moving because we want to reduce the technical burden of converting FHIR to SQL. So we are trying to move to the native FHIR server for that, but the issues with complexity with the DHIS2 still remain because we currently don't have like a framework. How do we convert that data model? Where do encounter fits, for example? Where do we use ICD-10, for example? If we want to use it to options, then what are the implications? Will there be any data loss, etc.? So it's not answered yet. So we're here, and we think that some of countries will also move to FHIR because the WHO has been heavily promoting and advocating for it. So I think this will be our problem together. So yeah, technology alone doesn't ensure interoperability. And with implementation, we did with small pilots to help with feasibility and user needs. And we do think from technical perspective and in the end from the user trust for the data, standard frameworks matter. So maybe we need FIRE to the DHIS2 framework, maybe. And you have plan for data requirements because we initially did a plan for data architecture. So it became, just go along with it, and it was not very efficient. Yeah, so our suggestion and what we are advocating here is to strengthen the semantic alignment between what is advocated at the global level, especially from the WHO, and to help. It doesn't have to be a feature. It can be like in a form of technical guideline. How do we convert FIRE data to DHIS2, or reverse on the other way, DHIS2 to FIRE? How do you do that? And maybe can support hybrid data models, encourage open collaboration, especially because we have lots of open standards and international bodies maintaining that. Yeah, so from closing, from Taufik.
And, the final thing about FIRE is about not only interoperability. We're concerned about the data sharing itself, because the expectation FIRE is share the data between each other. Maybe the next recommendation is not only how to utilize FIRE only, but also how we can test data moving or integrate or interoperable between facility level. Thank you. This is from Indonesia. Thank you so much.
Thank you. And thank you to the teams both. The applause is for the teams both from, or the presenters from Indonesia and also from Sri Lanka. I know this is sort of a very interesting topic for people because, and it's great to see two countries leading the way there. Have we got any questions? I imagine there's probably some technical people in the room who do have questions.
Yeah, I'm Dr. Ashan from Sri Lanka Ministry of Health, and I like to know how you are managing the registries, because currently in Sri Lankan setup we don't have the registries managed with the FIRE, and especially if we think of user registries. So, how are you doing using that registry in DHIS2 setup or any other systems for authentication only, or are you directly checking with the registries for data entry and all? Yeah, that aspect. Yeah.
Yeah. Thanks, Doctor. So, in terms of the Satu Sehat platform, it's the health information exchange platform, consists of many registries. For example, individual registries data, facility registries, and also health worker registries. In the Satu Sehat platform, we are built some platform, sub-platform itself. For example, facility registries. We collect the registry itself and directly to the Satu Sehat platform itself. So the next here, how to communicate to each other. This is the registration process during our phase of the implementation. We call it like this. We call it like the Satu Sehat sandbox system. So it means they test first to test the process, and if there is a pass on it area, they will go to the production. And if we talk about the national insurance ID and also ID of the peoples, Ministry of Health have the MOU, technical MOU between Ministry of Home Affairs and Ministry of Health itself. So all data is routinely updated from Ministry of Home Affairs, converted to the MPI, Master Patient Index, and we utilize through MPI, Master Patient Index, or the Registry of Patients, something. This is very important. And the next of the health worker registries. This is part of the simulation from Ministry of Education, Ministry of Health for the utilization. We only get the data from Ministry of Health. To utilize of the health worker, we call like health worker registry and direct to the Satu Sehat platform. And if we want to share the information through FIRE or not, we connect to the area with the Satu Sehat platform itself. It's like the connections of to each other. Thank you.
Great. Hasley is also online, still from Sri Lanka, if anyone had a question specifically for him. Or for Indonesia, if there are any more. No, I think it's morning tea time, so I think everyone's ready for some food and to refresh. So thanks once again to the Indonesian team, and also Hasley, thank you so much. I think you're still online there. It was really useful for everyone to hear the experience in Sri Lanka and in Indonesia. So we'll break now for 25 minutes, and then we'll be back for data use and decision making. Okay? Thank you. Okay, if you're outside, could you come inside, please? Make your way in, please. We're running behind time.
Hello everyone, we are starting.
I'm not always the best with timekeeping. Have we got Nick there? Are you there, Nick? Just checking while people are coming into the room.
Yeah, hello. Can you hear
Hello.
me?
Oh, good, good. Just checking. I'll introduce you in a minute.
It won't let me start my video, so let me try again. Yeah, there we go.
Okay, we ready? So we're moving on to the next session, and the topic is on data use and decision making. And we've got three sort of topics within this: data use principles in DHIS2, public dashboards, and use cases from the region. So to begin with, we've got Surajit Dutta online. Most of you, or plenty of you, probably know Surajit. We're missing him here this year. He usually attends this conference, but couldn't this time around. But he's going to present on data use principles in DHIS2. So we'll get you to share your screen. Is it shared? Yep. Or when you're ready. Oh, great. We can see you, Nick.
Okay, you can.
Yep.
Okay, so yeah, you guys can see everything okay and hear me okay?
Yep, we can hear you and we can see your presentation and you.
Okay, great. All right, thanks, Michael. So yeah, my presentation is going to be a little bit different. I had a sneak peek at the other presentations in this session today, and they're going to walk you through some specific use cases, and I think they're good examples of data use in practice. What I wanted to talk about was just to kind of frame the discussion a little bit in terms of, you know, how we actually produce outputs and some of the considerations that go into that. So it's not really going to focus on any specific use case or any specific country or setting, but just a bit of a background more in terms of, you know, when we make outputs, what are some of the considerations we can make, and then, you know, what does the data look like when we review it in a certain way, and what are the kind of conclusions we can make from reviewing some of this information. I did want to highlight that we now have an academy on data use and triangulation. At the end of the presentation, I have some references, resources, etc., and I'm sure you have access to this presentation that I've uploaded to the Google Drive folder, so you will be able to access that. So that would be a good resource to look at if you're kind of interested a bit more in kind of the wider data use principles that we have. So that's a full 3-day course. So of course I'm not going to have time to talk about everything that we would cover in this session here, but just a bit of a sneak peek and talking about some of these principles a little bit more with you. So some of these might be familiar to some of you, some might not be. Hopefully there's some takeaways, and this is a good reference for you. And of course, like I mentioned, you'll have some additional resources at the end. Okay, so in this session, what I'm going to go through before I hand over to the other presenters is actually just walking through a couple principles as I mentioned. So the first thing I'll talk about is selecting the correct visualization type depending on the data that you're working with. And then I'll talk about the description of some of these different visualization types, talking about the different data that gets input into these visualizations and why it makes more sense to use one versus the other. I'll use some common examples or just present some common examples where mistakes can be made when creating different visualizations. And then we'll kind of tie this all together by discussing, when we're actually making a dashboard, how do we actually make that in a way that makes sense to people, and that's kind of easier for people to navigate, interpret, and view when they're using these dashboards. And then the last thing I'll touch upon, I'm not going to spend a lot of time on this today, but maybe for future reference, is just kind of DHIS2 data use beyond what I'm mentioning here, beyond indicators, beyond dashboards. DHIS2 is really a treasure trove of data. It has a lot of information that you can use, and you can do other things with this information. And I understand there are some of you in the audience who are statisticians or have that background, and like I said, I won't spend a lot of time on this, but I did want to bring it up because I do think it's important, and I think that it's something we don't see a lot of necessarily, but the information that we have can be used in a lot of good ways. I will just talk about some examples at the end, just to kind of cover this in a bit more detail. All right, so the first thing I'm going to talk about is just selecting the correct visualization type depending on the data that you're using. So there's a lot of different ways to go through this process, but the whole idea is depending on the data that you're using, and there's more information on this. We have what we call qualitative data, which is split up into categories. So this would be things like sex, for example, where there's distinct categories for male and female. You have things like responses in a tracker program that might be split up into yes and no. We also have something called qualitative variables. This is numeric data of some kind, right? And depending on the data we're displaying, depending on kind of what we're choosing to display, there are kind of good ways to display that information that make more sense. So I'm not going to go over all the components of this right now, but I'll just leave you with this kind of resource so you can understand that depending on what we're looking to convey, there are correct ways, or better ways, I should say, to select the right visualization. And these chart types that are shown here are mostly, for the most part, supported inside of DHIS2. So there's a lot of different options depending on what you're doing. And just these 4 categories here that are kind of highlighted in the center, comparison, relationship, composition, distribution. This could be a bit of a cheat sheet in a way, just really quickly. I mean, it's not something you have to really think too much about, but just really quickly thinking about, well, what am I trying to show, and what is the proper chart type that would help me convey that message in an appropriate way. So I'll just focus on a couple examples just to explain this a little bit more and discuss why it's better to often choose one way of visualizing the data versus another. So the first thing I'll talk about is a correlation. So this is a relationship between at least 2 variables, could be more. And we have different ways to kind of create charts in DHIS2 to describe a correlation. The first one is a scatter plot. And we can use this in multiple ways. We can also use this to identify outliers, not just identify a relationship between 2 related variables, but also identify if there is significant differences between these outliers. And we've incorporated some statistical techniques in order to verify or quantify that. But the main thing here is that if I'll zoom in a little bit on this chart. Okay, so this is a DPT1 to 3 dropout rate compared to DPT1 coverage rate. Okay, so we have these 2 related variables, and we're kind of trying to understand, ideally the numbers here have some expected relationship that we can then review and make some judgments on, make some conclusions about. Here we have another chart here, which is a combination of a column and line chart. And the main thing that I wanted to focus on here is if you have a look here, the bottom row, it might be a little hard to see, but this x-axis, this bottom line, is the months. And what we like to emphasize is anytime you're using a line chart of some kind, you want these lines to be in a sequential order of some kind, right? So if you're having, let's say, organization units at the bottom, the lines don't really make a lot of sense, right? They could be going up or down, but it doesn't really matter, right? Because you're not really seeing a sequence over time. It's hard to interpret what that line represents other than the fact that it's representing a value of some kind, but that doesn't necessarily mean that you're seeing any relationship that you can take away from that line, right? So in some cases, you might want to see the line go up, you might want to see it go down, whatever the case may be, but you can't make that conclusion easily if you're using the wrong type of information when you're making these charts. So in this example, we have the number of measles cases, and then we have MR1 and MR2 coverage. So we have a comparison between a rate and a number. They're on different axes, etc. And then we have this line chart that's showing the relationship between this coverage over time. Now there's some issues with this coverage actually, as we can see, because it's kind of hopping all over the place from month to month. So that would be something else you could check, but we're not really talking about the specific data necessarily, just how to visualize this information. Okay. Ranking is another way if you're trying to show information, and this is why we have certain chart types in DHIS2. So you might kind of, we have the vertical column charts, we have the horizontal kind of bar charts in DHIS2, and we often see them used in different ways. All we're trying to convey is, there are some specific ways that these can be implemented that make a little bit more sense. So for example, if you're trying to rank performance between org units, right? That is a very good use of this type of chart. It allows you to see where they lie. You can sort the order from lowest to highest, and then you're able to get a better understanding of where they lie. So you could use rates in this scenario. You could use raw numbers in this scenario as well, case numbers, case counts, whatever it might be. Okay? We also have, this is another example here where I touched on it before, right? The line chart. In the other one, we had an example where we're still using the time as our x-axis, and generally speaking, that's what we tend to recommend when using this type of chart. The org units are the lines themselves, so we are seeing the change over time for these org units, but you typically wouldn't want that on your x-axis, just because you're seeing these up and down arrows based on the lines you're seeing, and it's kind of difficult for people to interpret, especially if you're kind of trying to train people to analyze this data, right? I think that's the big thing, right? How do people interpret that? Ideally, some of these visualizations have some instructions associated with them, how you would actually interpret them, and the better you kind of follow basic principles, the easier it is to kind of take some recommendations away and apply them to these visualizations in terms of training people, telling people how to visualize this information and how to interpret this data by adding descriptions for each of these visualizations. So there's, in terms of changes over time, there's a number of different ways you can convey this information, and all these chart types are supported in DHIS2. So we have a basic column chart with lines between them. Okay, you can also take the column charts and kind of smash them together, and there's a reason for that, right? Where you don't have any space between the columns in the chart itself. You have line charts, which we've discussed a little bit as well, the column plus line timeline charts, and area charts as well. So these area charts in particular, this is these are a bit tricky to implement to make sure they make sense. They might look nice as a visualization, but you want to make sure that what you're making is not just something that looks nice, but actually makes sense based on the data that you've selected. The first thing I want to mention for column charts in particular is that they're not really adequate for rates, and we see this quite often. So for example, if you take a infant mortality rate or maternal mortality rate and you create a column chart for that, maybe because it looks easy to interpret. But the problem is the verticality between different boxes, the different columns in that chart, it doesn't give you any meaningful understanding of the differences between each column in that chart. Whether you're using organization units or you're using time periods, whatever it might be, populations, characteristics are different, and it's hard to make a conclusion about the information when it's displayed that way. So typically when we use column charts and we're looking at a change over time, what we want to use are raw numbers essentially. And there are other chart types that are better placed for rates. For example, this ranking vertical bar chart, for example, would be better in that scenario. A line chart is good when the data is irregular, but once again, you want that x-axis to typically be a period of some kind, rather than your organization units, the column and line discussed. So for area charts, I think we'll cover that in a moment. But we just want to make sure that it's good to show changes in totals, but when you have many components, let's say you break something up into categories, some kind, disaggregations, etc., it becomes a little messy, right, when you start stacking all these areas together. And you really don't want to have too many variables on that specific charting type because it becomes difficult to interpret. So just a couple examples of this. So for example, if I'm looking at a change over time, we could compare the actual relative size. So when I say magnitude, what I mean is the size of change over time, right? And we're trying to measure this to see, you know, and quantify, well, is there a significant change? Or, you know, is the change not really going in the direction we have? Maybe we have some targets as well that we would want to kind of add to this to understand this. But when we're dealing with raw numbers, we are able to more easily see these differences, right? Because we're able to see absolute differences in the chart itself. When we're using rates and we see kind of higher bars versus a lower bar, it's harder to tell if the magnitude of that difference actually is meaningful. So that's why we kind of stick to this in a way. So the vertical bar chart is the same principle in this scenario. When we're looking at things like performance, so this radar chart, spider chart, this is also one that's typically used in a way that you know, might not always be correct. It's good to break something up into kind of specific categories. But what you don't want to do with these charts, one, you don't want to have too many categories on them because it gets, you know, too much, right? So we kind of try to restrict these to about 5 categories in our breakdown. Here we have different rehabilitation services on this chart. It might be a little hard to see perhaps on the screen, but I'm sure if you open the presentation, you can also have a look. What we don't want to do is look at changes over time on this chart. So for example, having time periods. And then, you know, having this chart that kind of does this graphing over time, it's not the kind of right way to approach this, okay? So just make sure that if you're using this chart, it's not that you shouldn't use it, but just use it in the correct way. You know, it becomes difficult. It doesn't really become that meaningful if you're kind of making charts that are difficult for people to understand. We also have other ways of breaking down these categories. So the spider or radar chart is a good way. A pie chart can be very useful in certain scenarios, but we also similarly don't want to see overuse of this. So when you have two or 3 or 4 parts that add up to a total, this is where things like stacked column charts that don't have any spaces between them and things like pie charts can be very useful. Once again, I think in this case for the pie chart, you know, breaking things up by periods, by time, that's not really the most appropriate use of this. But if you have things like sex, breaking things down by sex, this is a very useful way to break that down. But what we sometimes see is an overuse of this charting type. And, you know, typically that becomes problematic because, you know, once you start overusing these, they're kind of all over the place, they're well spread, and then people have difficulty interpreting them. Okay, another good example for this stacked or column bar chart are things like epicurves or things like deaths, when you're kind of wanting to see if a significant change over time is happening, and if there are more than one category that those items are split up into. So for example, deaths could be clinical, or deaths could also happen out in the community, for example, and you might want to see if there's significant changes or drops over time. When you're using these stacked charts, it follows a very similar principle to some of these other ones. You don't want too many categories within each stack, within each column. So you're trying to kind of make sure that you convey this appropriately, but you don't want many bars because the problem is once you stack them all together, they'll all be side by side, there'll be changes, you know, the colors won't line up, it'll become difficult to interpret. Let's say if I have 5 or more in there in each of these stacks, then it just becomes difficult to manage and difficult to view, especially if you just want people to have a kind of quick glance and then be able to interpret that information. So another kind of common way, of course, is to use the spatial features. And unfortunately, we see, you know, there's quite powerful tools in DHIS2 in order to create maps. And in addition to what's in DHIS2, you know, we can export that data out, and we can use things like QGIS or ArcGIS and use the GeoJSON files that are produced by DHIS2 to perform quite detailed DHIS2, specific spatial analysis. So for example, we can't make a heat map inside of DHIS2, but we can take the data from DHIS2 and make a heat map in something like QGIS or ArcGIS. The other ones we see here, choropath maps, symbols, and dot density maps, we can actually make these in DHIS2. So there are a lot of types of spatial features that are there. But when we make these maps, it kind of follows a similar set of principles where we're kind of trying to select the right output to make for those maps and the right approach for this. So for example, this first one here, this choropath map, the idea here, in a lot of cases I said, for like a column chart, for example, I said don't use rates. Choropath maps are a good example where you should use rates. Where using totals, for example, across the geography, it doesn't reflect the size of the population necessarily, let's say, and therefore a raw number, it can make sense in some specific scenarios. But for the most part, it's often better to use something that includes a calculation that standardizes the values across the geography. So when I look at that geography, if one is greater or less than a neighboring piece of that geography, I can make a conclusion about its performance. I can make a conclusion about the indicator value based on the relative number that I'm presented with. When you are using numbers, it's better to use this bubble chart. Okay, so that's the chart, or bubble map, sorry, that's the map type into DHIS2. So anytime you're using totals, anytime you're using raw data, that's when you want to use these bubble map types. And the bubble will increase or decrease depending on the value, and you can have them in different parts of your geography and display them. You can combine the choropath map with the bubble map as well, of course, by having separate layers on the map. This final map is good to show the location of items. So for example, if you have a disease surveillance program and you're collecting the location of cases and you want to display them on a map, or using it for anything else, any other type of service where you're collecting the actual location, then it's very good to use these point type maps. You can, if you do have your facilities in there, of course, and the coordinates for those, this can be useful in some scenarios as well, displaying raw values of some kind. The heat map is kind of very similar to this first map here, but you no longer apply the geographical boundaries, right? And this is not something you can make in DHIS2 at the moment. It's, you would have to use an external software. But it's very similar in terms of the principles. You could use rates, but then you're not so focused necessarily on geography or borders of geography. You're more focused on kind of grids of information where this is happening. This can be very useful, once again, for something like disease surveillance, but I'm sure there are other examples that you can think of where this can be quite useful. So, some common mistakes. So, yeah, these are some examples of some charts that, where we see kind of different principles applied. Some of these are quite extreme, of course, and difficult to interpret. Here we have this, but we've seen these quite a few times, right? So we have this line chart here, just has far too many values. It's difficult to interpret. We have maps here where the layers are in the wrong order or just using too much information to display in the right way. So another kind of common mistake, and this is one that I think we see quite often, is how the charts are labeled. The visualizations are labeled, right? So they might not have labels for the axes. They might not indicate what period the information is for. All this is possible to add, and I get it because it takes a little more time. After you make the visualization, you have to go in and edit all the options and save it again. And, it adds, 3 to 5 minutes for each of these visualizations that are created. But, if the idea is for someone to come in maybe without a lot of knowledge in the system or just really quickly view these visualizations on a dashboard, it's better to kind of give as much context as possible. Here's an example of a pie chart. I mentioned this earlier. So here we're using org units instead of just splitting them up into a categorical disaggregation of some kind. And you can see why this is not necessarily useful. It could in the case, it could in a case add up to 100% still. This one wouldn't because you have the country, then you have all the provinces. But if you excluded the country, maybe it still adds up to 100%. But it's kind of too many categories to display, and it doesn't really kind of aid the person in interpreting this specific piece of information. Another common mistake is adding totals when you have the different disaggregations included. So here you have the total, and you can see the scale of the total is much higher than the different parts. In some cases, this can make sense if your total is not a raw value. But when you are having a raw value where you're having a total, let's say, for your whole country, and then you're breaking this down. In this case, this example is by provinces. The scale is just too different between the two, and it doesn't make sense to put that on a separate axis or something either in this particular case. Some other examples of inappropriate chart types, I brought these up, but just to visualize them. So using this radar or spider chart, and then using the periods instead of kind of some type of categorical disaggregation, and limiting the number of categories once again. This is not, really reflective of any kind of meaningful trend necessarily. When you look at this, there are better ways to display this, like a line chart, for example. Would be much easier to interpret this. You would see sequential steps. You would see if the value is going up or down, whatever you needed to review in this particular scenario. Another problem here, and I mentioned this earlier, you have this line chart and you have a column chart, so this combined chart. The blue bars, the blue columns are HIV test performed, and the red is test positivity. The problem here is that you have org units as your x-axis. So while this line is kind of going up and going down or whatever, there's no real relationship that it's displaying in the line itself, because the line's just, it's a completely different geographical unit that's in each step of this, rather than looking at, let's say, a trend over time, which would be more appropriate for displaying this type of information. And yeah, there's several other kind of, I'll just skip over this, but yeah, we just have quite a few examples of some of this. So we do have some example documentation now on this that goes through all the detail that I've described. We have a number of dashboards that you can look at, and I think they'll discuss the public dashboards a little bit more later on, so I'm going to leave that to the teams that are there. So just a quick recap when looking at this. So when you're looking at considering your chart type and making your data, it's not something you have to spend a lot of time on. But I would encourage you to just think a little bit in terms of, well, what are you presenting, and what is a maybe appropriate way to present this that would make sense kind of immediately to the person that is reviewing that. So considering how many variables you have, if you have many variables versus having a small number, this can change the type of chart type that would be appropriate. Think of the purpose of your visualization. Do you want to look at something like a correlation? Do you want to rank the items and display performance that way? And based on that can also help you quite a bit in making a determination for what's the appropriate visualization to use. Try to avoid some of the common mistakes that I've talked about. Label everything if you can. Try not to use inappropriate charting types when you can avoid it. And then create the chart thinking of who's going to view this. Ideally, you make some type of visualizations that can be reused across different levels. When in doubt, there's a lot of guidelines that you can refer to, either ones here or there's lots of information on this that can be viewed. So quickly, how this relates in terms of setting up the dashboards. It can often be useful then. So once we start creating the right visualizations to represent our data, so actually what I wanted to point out here was something that's both good and bad. For example, these headline figures, they can often be enticing for the right audience. But in the case where, so for example, maybe program managers, etc., who are kind of really interested in this high-level information. Now, the issue with these headline figures is that it becomes difficult to drill down and to see the information in more detail. So, if I look at this visualization here, if I were to open it up in Data Visualizer, I have no way to further disaggregate this information. I can't select more periods, I can't select more org units, I can't figure out different coverages for different provinces or districts. I'm kind of stuck with this overall value, this overall metric. So just make sure when you're making those dashboards and when you're considering how people will use them, because this type of thing is very useful in certain scenarios. you know, like if you're displaying this in a national office of some kind, that can be very useful to display. But then, you know, someone else who might need to use this data at a different level, in a different way, there might be something, you know, that you should consider based on the visualizations that they're looking at. So it's not always the case where one visualization fits everybody. There could be different use cases that you have to consider. Even though, you know, the visualization is appropriate, it doesn't mean, you know, if I were to have a workflow set up for how I wanted a person to use that dashboard on a weekly or monthly basis, then I should kind of make sure to have the visualizations that would kind of ease that workflow. You know, that to the extent that it will allow them to drill down, investigate issues further, highlight, you know, gaps in the data, or highlight, you know, areas that are performing well, or look at trends over time, or, you know, whatever it might be. So just make sure to consider that there are different audiences for these different visualization types, and design your dashboard with that in mind. There's a lot of, when you're making the dashboard itself, there's a lot of ways to kind of space out the dashboard, okay? This can help with, you know, spanning the dashboard, making it look a little bit nicer. You can, you know, there are different modes now to print the dashboard. You can have these kind of full screen displays of the dashboard. I know there are some apps that also kind of connect to the dashboard to make it look a little bit nicer. But having this proper spacing, having the descriptions for everything, it's just in line with the principles, same principles that we had for these visualizations. So the idea here being that, you know, be as descriptive as you can, make proper spacing, you know, make it so that people can, you know, easily read what you created for them to do. Adding details is also another kind of very important principle on these dashboards. So for every visualization that is made, you can make quite detailed descriptions. And we talked about, this is the principle that I kind of press upon in most trainings even when you're showing people how to make visualizations, only because we don't see it very often, right? And the idea is that, you know, if your data is performing in a certain way and you expect some type of action based on, you know, that data. So for example, you notice in some months the immunization rate is dropping, and it could be maybe because of stockout, it could be because of facility closure, it could be something else. But the idea is, you know, you should have some steps to investigate that, rather than kind of leave it up to the person to try and figure out, well, what do I do now? You know, or do I just look at this data? I've logged into DHIS2, I've looked at my dashboard this month, some of the data looks okay, some doesn't, and it's time for me to move on. So ideally you would have, I know there are often meetings about this, where you bring the data together and discuss it, but I think it's also useful to kind of have some of that individual instruction for the person that's reviewing these, especially for those kind of key metrics that you expect them to act on. Some of them, you know, it might not be a monthly basis. You know, if you're looking at something like life expectancy, you know, it's not something you can act upon immediately, but there are others, right, depending on the program, where you can act upon a little bit quicker. Also, including things like SOPs on the dashboard, things like targets, for example, is also useful if you include them in your visualizations itself. Using legends to describe, you know, coloring, make it stand out, and make it easy to interpret. Where possible, of course, it's not always possible if it's just a raw value, but when you're using rates or coverages, things like that, then it can be quite useful. And then, you know, things like messages or interpretations as well. So often it requires a bit of collaboration between, you know, whoever's kind of well-versed in using DHIS2 and maybe a subject matter expert of some kind who really understands the program. Not to say that can't be the same person, that often can be the case, especially when it comes to working with the visualizations of the tools. But the whole idea here is that you do have some of this in place versus kind of, you know, leaving it to you know, people's own individual action. So I, you know, while I understand there are often gatherings, meetings, bringing the data together, discussing that, I think that's all very useful. But just including some individual points for these people to kind of, you know, when they see this, you know, what do they actually do with this, and how do they interpret this information? It can be quite helpful. And there is a lot of guidelines actually for different programs. And this is something WHO has worked on actually a fair amount in terms of making guidelines to interpret specific visualizations. And it's something that you could kind of, I think, really have a good look at to get an idea of a framework for yourself. If you don't have one already, if you do, of course, then it's just a matter of, enforcing that a little bit more, perhaps.
Surajit, we're a little bit pressed for time, so I might need you to just move a little bit quickly for a couple of minutes.
Sure.
Thanks.
Yeah. So there's a bunch of other stuff here about additional stuff you can do with the dashboard. And the last thing I wanted to just touch on is that, beyond everything we discussed, using DHIS2 for, showing indicators, making dashboards, there's a lot more you can do with that information, right? There's all kinds of statistical tests you could run on this as well to look at correlations of your data from, really make a public health case for improvement in your services, right? So sometimes we just say, well, this indicator, it was, 45% and now it's 62%, and that looks good, that's an improvement. But we can actually do some more science behind this to really show significant changes over time. I've just put some links here. I'm not going to go over this very much right now, but if you want for your own advice, and then there's some more resources here as well that you can look at. So yeah, thank you very much. Sorry I went over time. I'll hand it back to you guys.
No problem. We've started a bit late too. Round of applause, yeah. Now that's very timely, of course. This session's all about data use and using data for decision making. Of course, DHIS2, it's nothing unless we're using the data and making decisions based on that. And what Nick's really, or Surajit's really showing us there is that if the dashboards and the tables, the charts are not interpretable, then it's really difficult to make those decisions. Okay, I think we might need to press on without questions unless anyone had anything burning. Okay, so we're going to move on to public dashboards now with Hanan from HIS Bangladesh. Thank you.
Good morning. So, how is the gala dinner yesterday? Enjoyable? With dance and music? Okay. So, Surajit already laid the baseline for my presentation. So, data visualization is quite important, and we need to present it properly so that the visualization data use case should be understandable for everyone. But in DHIS2, the issue is just need to username and login to enter, and he have to make his own visualization or presentation, or someone should share with that. The concept of public dashboard, actually a public dashboard is a vital tool for a country's health system as it strengthens accountability, evidence-based decision making, and citizen engagement. So that's actually the So this is the main reason why we're using public dashboard. One thing is, for example, government officials, they usually forget the username and password for their DHIS2. So in quick, when something required, he is asked to someone. So instead that, we create the national health dashboard, but there is several dashboards, so we go one by one, so that they can do without any username password, as well as the people can directly access to the system and use the data, and also for other purposes. So let me show our dashboard, National Health Dashboard, how we use that and how we assist the government to improve the accountability as well as data visualization, data interpretation, and decision support system. So initially this dashboard is developed by us So another important requirement is the development partners reporting. So many of the health programs are funded by the World Bank, ADB, UNICEF, WHO, like that, and they need some sort of regular reporting, especially the bank. ADB and World Bank need every monthly, quarterly, annual reports. And there is pre-formatted report, and I will show also another dashboard which is producing this kind of report. So first we go for the National Health Dashboard for the Government of Bangladesh. Is the dashboard.dghis.gov.bd. I'll share the all 4 dashboard we are showing today with this link with this PowerPoint presentation and share with you all, so that you can, when you're returning home, you can explore and you can build your own country dashboard as well. So the openly sharing data on service delivery, disease surveillance, health programs, performance enhancement accountability to real time and real or near real time, because sometimes it's not real time. For example, DHIS2. So monthly it is updated every month. When is daily tracker based data is usually updated next day. So most of the tracker at 24 hours delay. So one data is entered today will be updated dashboard in tomorrow. So that's how. So we said it in nearly real time. So this also helps us to monitor the SDG goal, specifically SDG 3, which relates to the health. Initially, this dashboard was developed in 2016, the first version, developed jointly with the SHARE project, European Union funded project, DHIS Bangladesh, WHO and UNICEF. Later, after a few years, I think after 3 years, we handed over to the UNICEF. So UNICEF technical team, they are actually maintaining the server. Now for last 3 years, the government itself is maintaining the dashboard. But with this, definitely most people are from outside consultant. But we observed that there is a lack of monitoring data, and also the dashboard are become quite clumsy because no proper way they are expanding the dashboards. So that's also one governance point you should remember. So that is the dashboard outlook. So in that point, I go to the demonstration for the specific dashboard. So and I'll not go for all components. I actually go for 3 major components. So this is the public dashboard. On the left, there is menu, and several dashboard is there. So one by one, the first one is the COVID-19 dashboard. You know, the COVID pandemic is over. So, but still there is COVID cases. So COVID dashboard is reflecting all those things. Shareable health records. Actually, we are also implementing SSR, shared health records. So it's actually accumulation from OpenMRS implementation, DHIS2, OpenSRP, all systems together. But this is also in infant stage, so data is not properly updated yet. And DHIS2 data is also not incorporated yet due to the terminology registry they build. There is also no mapping with the DHIS2 yet. But when the DHIS2 will be the main data provider of this shared health records, because 90% of the health data are generated by the DHIS2. Smart Health BD is the OpenSRP product, sorry. So it's actually OpenSRP implementation, and the routine health live data, which is actually the basic interest. So all routine live health data is actually coming from here. So if you go to the routine health live data, this screen will be look like that. So on the top menu, there is a reporting rate, data quality assessment, maternal, newborn, EPI, adolescent, hospital service, nutrition, EMIS, urban health, MCCOD, VA, verbal autopsy, GIS, and many things there. Okay, so I just started, not 10 minutes. So from there, we'll go for every bits of statistics if you want. So for example, if I go to the causes of death, then the causes of death summary, you can see the causes of death summary from here. And you can also drill down whatever you want. And from that, you also can download the data. So this is the public health data. So people can analyze from here. And if he has any question or confusion or has a doubt, he can also challenge the Ministry of Health. So this is actually the accountability of the data. They are actually presenting what's public health, their health data they are showing. So routine health data you can explore this way, but the next what I show you is I think, so this is the health system strengthening dashboard, the component, but this is one key dashboard. I actually go through 3 key dashboards. One is the health system strengthening. So you know the WHO building blocks, according to WHO building blocks, we build this health system strengthening scorecard. So what is done? So from DHIS2 HRIS, human resource and everything is come to this place to make the facility scoring. So if you see on the left, there's the Upajala Health Complex. So this is the top 5. Every month's performance, many things. One is data quality, timeliness, and also we have grievance system. So complaint management, how many complaints? The less complaint they have, they will be higher the score. Also for several other components is there. So all 7 building blocks are addressing here. And this is for district hospital, medical college hospital, and super specialized hospital. I don't know whether you can read from the behind, but I share with the link so that you can explore yourself for later on. But this is actually the basis of the yearly presentation, yearly honor from the health minister. So health minister's award actually given from this. So this is for every month the scoring, and yearly there is a scoring, the average they do, and also there is a field validation there. So there is one team go from here to there to make the field validation, and after that the health minister award is provided. So this is another strong tool, because this is the encouragement. The people are entering data on time and improving the data quality. If they have the last, they are very ashamed because everyone is there. So all 500 sub-district facility head is there, and only 5 are awarded. So first, second, third is awarded, 2 is appreciated, and last 5, they also saw the score. They are the last 5. So they are a bit ashamed, so that next year they will improve their performance. So that's how as we cannot give the financial incentive, so we do it this way. Another part is the local health bulletin. This is the automatic generation of publishing report. So within pre-formatted booklet, they are providing from this. So this is by facility. So 25, and this is by month. So if I select some, for example, I see 24. If I select view, then that specific facility bulletin is ready. So this is a PDF format bulletin, pre-formatted. So all statistics and everything is there. This is presented and printed, and this is the basis for the monthly meeting of the district, sub-district level. Within this bulletin, they are actually discussing the meeting. So this serve a role for the improving the data quality and the timeliness. Now we go back to presentation again. So next dashboard, I go to the urban health dashboard of Ministry of Local Government. You know, in Bangladesh, as per constitution, the urban health, primary healthcare divided into 2 parts, urban health and rural health. So urban health is under Ministry of Local Government, Ministry of Local Government, Rural Development and Cooperative. And for the rural area, is under Ministry of Health. So Ministry of Health is quite well, but urban health is actually maintained mostly by USAID, ADB and World Bank. Except the ADB funded projects, other projects are not much data collection, they are using other systems, and after USAID gone, all the projects shut down. And there is no data collection, no system memory, no institutional memory, and no reporting left. But in the DHIS2 system, which already closed in last June, but still they are running by the government itself. So our city corporation and municipalities are running all clinics, including the HMI systems. So the reporting is still ongoing with those HMI system, and this HMI system fit our national urban health dashboard. So in that specific dashboard, there is 2 purposes of the dashboard. One is the core indicator analysis, and second part is the regular reporting of the pre-formatted reporting. So one major reporting is required is a quarterly progress report, which is going to the Asian Development Bank and External Resources Division of Ministry of Finance. So Ministry of Finance need a quarterly progress report with how many services they are providing, including some financial data. And this is one core example where we use the tracker to aggregate in the DHIS2. So we use the DHIS2 internal mechanism to make a tracker to aggregate and aggregate to dashboard. So this is done by every month they do the aggregation, and there is the approval by the clinic head or clinic manager, and then finally we have the quarterly progress report. And this is one good example of how the timeliness and data quality is improved. Why? Because every transaction relates with the money. Because here they have to report the money as well. How many services they provided, how many earning they have, and how much subsidy they are providing. The subsidy to poor and ultra poor. So that's also quite important. So let's move back to the demonstration of. So urban health dashboard looks like that. So in each first pages, you can see the core indicators, what they usually monitoring. So all indicators are here. And in the second portion, because this is there's an interactive button there. So if we go, so dashboard menu, there is option for last 12 months, this year, interactive, quarterly progress report and annual progress report. So let's go to the quarterly progress report. So quarterly progress report actually pre-formatted according to ADB requirement. So this is actually ADB format, and when there's a print option, this print option actually printed as per ADB format, PDF format directly, so that they can put it in, combine all those PDF and submit to the Asian Development Bank. Also the ADB, the same report goes to the ADB and Asian Development Bank. So that is required, and there is several pre-format graph by NGOs. So this is actually near about 104 pages. So that's produced 104 page report from the data. So that's quite important, because this is the prerequisite of the donor to have this reporting. Similarly, ADB also required an annual progress report. This is also the same, but the point is you can change what you need by period. So here is the option, you can change whatever old QPR you need. So from the beginning, 2018 to all QPR you can regenerate and you can have from that. So that is actually quite important, because people usually lost the old record or PDF, and here they can do it quite easily. And for the final one, we go to the presentation again. So final one is National Cancer Dashboard. So National Cancer Dashboard is the first cancer dashboard for the government of Bangladesh. Initially we start with the cervical and breast cancer, and cervical breast cancer we have the useful tools for monitoring cervical and breast cancer. And so cervical breast cancer we already discussed yesterday, so I will not go much on that, but we will share the link as well. So the cervical breast cancer link is that, and you already, I show you yesterday, and possibly you already remember that, maybe you already explored. And few other dashboard we are also in on progress, work on progress. So 4 dashboard now currently we are preparing. So one is AEFI and VPT surveillance dashboard, which based on our AEFI and VPT surveillance database in DHIS2. Second one is the dashboard on nutrition, especially the which we call Mukto dashboard in Bangla. So this dashboard initially built by the UNICEF now is handed over to us to rebuild the dashboard based on the routine health data. Dashboard on hypertension and diabetes control, that's actually for the simple data and all other implementation. But unfortunately, all other implementations doesn't share any data yet with the national HMI system. So simple data only sharing the hypertension and diabetes data. So this data we are now have a DHIS2 dashboard but they want a public dashboard so everyone can see this data. And fourth one is the SCANU and Kangaroo Mother Care dashboard, so which is the requirement for UNICEF, and we are actually working with the UNICEF to complete these dashboards. So again, so all dashboard we will share with you links so that you can go for it, and if you need, you can contact us. Thank you.
Thanks so much, Anand. And sorry, we're putting everyone under a little bit of pressure time-wise here, but thanks for that great presentation. I think, as Parmod said yesterday, the fact that you share all that information and people can access that information is really, really useful, both to encourage use, but also that whole feedback cycle around data quality. People can interrogate and they can say, well, is it entirely accurate or not? And that can help your processes as well. But look, we'll hold off on questions. If there are any, we'll have some at the end of the session, but we'll move on to use cases from the region. We're going to use cases, so this should be an interesting presentation. We're going to give Jorn a couple of minutes to introduce.
We can get up the now presentation because the two first up with the Lao. We have two presentations which are part of what we call the Health Data Collaborative Use Case Study. The first one is from Laos, and the second one from Sri Lanka. And this is part of a project with HTC on data use, to study data use in the countries. And one motivation for having this here now is that we will maybe after the last presentation, after this session, we will discuss how can you guys do a similar case study in your country. And that is the motivation. And the case study is about how to use and how is actually data used at the local level, and to see that in the context of the national systems and potential fragmentation and poor integration and things like that, but looking at the local in the context of the global system. So that, now we start with Laos and then Sri Lanka. Oh, you have this one.
Okay, thank you, Jon. Good morning. So I will start first for the Laos case study. So the assessment team led by Dr. Chansali and co-led with Jon. So we did the assessment in 2 provinces in Laos, and happy to share with you in terms of the key findings and some of the recommendations we found from the study. As Jon mentioned, so this is the WHO HDC working group to conduct the case study on data use. The objective, even though we focus on how the data used in district or facilities, we also did a further step to assess the provincial as well as the central level, just how to see how they use data, any barriers, any challenges, and then we'll come up with practical improvement. And the idea is to co-design with or co-develop the plan with them, so that this is something that they would like to use, and this is something that is their ownership. Just before going to that, just a brief on the context, just that you see or you understand or you have some ideas maybe in terms of the challenges of the country. So Laos is a landlocked country in Southeast Asia. So if you can see, Indonesia is on the south, Laos is a bit in the north. It's a landlocked country with a small population, about 7.5 million people. So we have 18 provinces and 148 districts. In terms of DHIS2 implementation, we share with you, Dr. Chancellor share with you on the first day. So right now we just surpassed 10 years, 12 years now. And most of the data entry are moving to tracker. So we still have some program reporting in aggregate about 30% and 70% are on tracker. But now in terms of digital maturity, right, yesterday we discussed about DHIS2 maturity. Specifically for health or DHIS2 now is quite advanced. But in terms of digital as a whole, for the whole country, across ministry, UNDP did the assessment in 2022. In terms of the country, it's only the score is really low, only 1.7 for the whole country. For the ministry, is about 1.8 across ministry. Ministry of Health is doing quite well, but other ministries still lagging behind. Then in terms of the provinces, it's still even lower than that. It's only 1.3 in terms of the digital maturity score. So at least this is something you get to understand how challenges in terms of using the digital solution in the country. In terms of the selection criteria, I mentioned we selected 2 provinces, but these 2 provinces we would like to compare between one in the north and one in the south, just to see how well or any key differences between these 2 in terms of geographic location. But then in terms of the size, we pick kind of similar size. And in terms of capacity, infrastructure, and budget to operate, I think these 2 provinces are still similarly the same. So then we can see, and in terms of readiness, these 2 are quite well ahead compared to other provinces. So might be interesting to see in terms of once you have all the things ready, how people are using the data. Approach, Johan already mentioned a bit, but I can just keep that into key findings, right? Because we visited starting from facilities, district, province, and then central level. So I will also follow the same step to share with you from bottom up. Right? At the facilities, which is the source of data, so here is where people collect and use most of the data. But what we find is that because in Laos, we cannot remove paper totally, right? And paper is still the base or the primary source of data. So then, at the same time, when they want to use data, they refer to paper or the paper book because that's what they are more comfortable with, and that's what they use it on the daily basis. But what we want to see is that now with digital tools, that many things you can do more in terms of data, but it's difficult to change or to tell them that to use DHIS2 to do more if the benefit is not clear or it's not obvious, right? In terms of checking about reporting the numbers, they can always refer to the books, which is easier, right? They don't have to open the laptop, log in. But what we want to show here is a clear, at least uptick in terms of using the data for action. The clear one is on EIR. Like I mentioned, we just celebrated 1 year of EIR implementation. Right? So this is something that will be difficult to do in the paper, because what I'm showing, one of the example is the appointment, right? So facility, they want to know how many children are expected to come to this facility, let's say this month or next month. So if you do in paper, you need to go through all the line, start counting, and start mixing the date. But with DHIS2, what we see, they prefer to use this report on the daily basis or monthly basis, because from tracker, you know the appointment date. It will just pull out all the list of children that are due in this month, or maybe some even overdue. So this is what we see, that a kind of something that now they're starting to use in terms of data for EIR, and that's the plan that we will continue to expand. And then this is something what we see facility will benefit a lot from using this type of data, because in their own benefit is to improve the service for their communities. Right? So that's one thing we've quite interesting to see. Yeah, and the phone number too, because they need to follow their child, and if the child is expected to come but they don't find it, they always have the phone number to call. So this is something, a clear example that we see. That's a good thing that switching to tracker can benefit the facility now. On the district level, what we find is that there are some meetings happening regularly, but usually it's about checking data, about checking the completeness and quality. So they're not using it to monitor the indicators or to do some gap analysis. Because what we find first is maybe the next slide, but then I can talk it here about the denominators. It allows the denominators stop at the district level. So that's what you get from the government. For district to do the planning or to support facilities is quite difficult when they don't have the denominator per facilities. So that's something we can do to improve that. So that's why now what they can do is only see the data coming from facilities and just checking the raw counts. So in terms of action, it's still limited there. Then we also find the staff rotation and even the capacity of the staff quite vary. In different districts, we have different capacity and staff rotation, and in terms of staff literacy of using the digital tool. And what we find is, because we also ask them to share us the presentation, what kind of report they do, and usually we saw that mostly from Excel, right? That's what they are more comfortable with. They download that and make it the chart graph in Excel, put in the report, put in the presentation. Same for provincial level. So in terms of the provincial, even though these two provinces are quite similar in terms of the size, the economy size, or in terms of capacity, but the practice are a bit different. For the one in the north, in Luang Prabang, they are doing quite well in terms of reporting, checking data. They even did their own initiative to collect facilities head count or in the catchment. But in Jampasak, they do have regular meetings to check the data. So what can we find the key success here is the champion in Luang Prabang. So he used to attend our training in Ho Chi Minh, used to attend this conference. But that is lacking in another province. So I think the key finding here, we want to create more provincial champion. At least start with few provinces, and then if we can build more, that will be a key driver. In terms of the central level, yeah, that's what most of the thing happen. So they have many priorities, but limited resources, right? And what we also see, because now at the central, they are the one who is responsible to report to higher level, to the minister. But what we see, they usually just compare the percentage, the coverage, right? But rarely they use analyze. Even though we talk about analyze, but when we ask, why don't you use analyze this? The concept is still lacking, or people understanding of analysis is limited. And what we find is the challenge is that because when you monitor percentage coverage, there's no action you can do, right? Because you only can see numbers going up. But then by the end of the year, compared to the target, then you see, we might not achieve the target, but then you don't have the time to fix it. So that's a kind of a next step. We want to emphasize on analyze, so at least you know how far you are doing right now, and then don't have to wait until the end of the year to know that if you achieve the target or not. And mostly because of the funding and support are coming from the central level, so they are more dependent on those areas, and usually this funding will focus on training or the supportive supervision. Okay, so I think I also included the recommendation or the next step into the key finding, but just to highlight it, 3 things. So the first is we don't have the standard. Right? That's what we see Luang Prabang is doing kind of their own interpretation or their own understanding of data use. In the South, they're also doing this, their own way of doing. But then Jon also mentioned now we need to standardize. Maybe these are the clear guidelines, this is what you need to check, this is the frequency you need to conduct the meeting. And for us, or even for me, because I'm doing local, I think this will be helpful, because to conduct this kind of thing, you need budget, you need finance. And if we have this standard document, something that they can refer when they make the plan, that will be a good one for them to have a regular one. The second one on the dashboard, we need to have, do have the default one, but what we found is that usually we only have one type of chart, but people will want to see more than one type. So what we want to emphasize now, okay, we will have one indicator but different type of visualization, like Nick just mentioned, so that people might get attracted to different kind of chart, right? So that at least it triggers their interest to look at the data. So that's something is in terms of the next step. We will have one indicator, different interpretation, different visualization that they can use. And the last one we'd like to talk about, now when we talk about, we want people to use data, we only focus on training. And as we can see, there's only one-off training and no follow-up. So right now we are planning with the ministry to try to conduct kind of a series of trainings or mini trainings along the year, so that, okay, start one by one and then expanding what to see, or to help them to identify the gap and come up with a good standard way of using the data. So that's all for my presentation. So next I would like to hand over to Pramod for Sri Lanka.
Yeah, handing over to Pramod. Thank you so much, Sam, on the Lao experience. Just a quick note, there was an announcement about the prayer room is available now in what was the room called again? Arjuna room, for those that are interested. Okay, thanks. Over to you, Pramod.
All right, good morning everyone, or afternoon rather. It's 12:18, so I'm standing between you and the lunch. So for this presentation I'm going to share data use experience that we did in Sri Lanka. While the slides please, yes. While the slides show up, yeah. I have extremely elastic 17 slides, so let's see how fast I can move. Right. And I'm presenting this work on behalf of the Family Health Bureau, the Ministry of Health Sri Lanka, who's a custodian of the data as well as the process, and the WHO and HIS Sri Lanka, who were part of this data use work that we conducted in Sri Lanka. All right, so this photo that you see here, my colleague shared beaches, historic sites from Sri Lanka, and this is from where? Ubud, Bali. Looks very similar for the Indonesians here, but no, this is from kind of a mountainous area in Sri Lanka. Okay. So, a little bit of context. We have a 22 million population, but the land area is around 65,000 square kilometers. One thing I want to highlight here, so Sri Lanka is not all about the coastal area. We have a high mountainous area in the central part as well. So what I want to emphasize is whenever we do field work and whenever healthcare workers do field activities, the terrain is very different, and that is something that we always have to take into consideration. Okay. Moving on, a little bit about the health sector in Sri Lanka. It is very important to note this before you do any kind of a field activity. So it's free healthcare at point of delivery, the government healthcare service. And when it comes to the organization arrangement, we have curative and preventive health sector separate. Okay, meaning the hospitals providing or giving treatment to patients is arranged in a specific manner compared to the preventive health sector, and this field work that I am explaining to you is only related to the preventive healthcare sector, and the context is RM and CH services. So we have the Ministry of Health, then we have the provincial level, regional/district level, and then we have very important level is this one, medical officer of health who's kind of in charge of all the preventive health care services in a sub-district level, and the public health midwife who's conducting all the field health activities. Right, about MCH information system, very important, we had a really robust paper-based MCH information system which has been functioning, well functioning for decades, right? So the challenge was we had to do a digital implementation, and the main concern was what? Not to break the existing system, right? So we introduced digital, but we don't break the very robust existing MCH information system. So the initial information system implementation on DHIS2 was in 2017 countrywide. And one thing I want to emphasize again, the lowest level, the aggregate system still is at paper based, but everything from the sub-district level upwards is digital. But this, even the lowest level data is inserted digitally at sub-district level, right? Meaning the public health midwife is not collecting data or inserting data into the digital format at field offices, right? That is due to a logistic concern. Okay, moving on. Of course, this is usually our healthcare worker at field level doing MCH activities, and she has all these forms and few more books, volumes of books, and the digital system, while doing, benefiting a lot by getting rid of all the inefficiencies. One main thing that this system has is validation rules. And why do we need validation rules? For what? Question. Exactly, it's about data quality, right? So that is one main thing I wanted to highlight. So they have, I don't know how many, almost 200 validation rules for these two main forms which is there, just to make sure that there is a good quality data. Okay, I'm not going into too much of details about other things. Okay, let's look at the team involved. The most important person for this work, of course we see Jon also here, but I'm specifically looking at the public health midwife. She's the champion who collects data as well as who actually performs all the public health activities related to maternal and child health. And then we have this sub-district or MOH level team headed by this guy. He's a public health medical doctor who's kind of leading all the activities. And then we have the public health nursing sister who's kind of like the supervisors of all the field health workers. And of course, we have public health inspector. Of course, he looks like he's wearing a police uniform. In fact, like the activities he's doing is considered like that in a way, because the people are very scared because he does all the inspection activities related to food and things like that. And we also have the data entry user. Right. And at the district level, this is the team. We have the medical officer who's leading all the MCH activities at district level. And then we have the public health, the matron. So she's kind of like supervising the public health nursing sisters and related activities. And then we have the specialist in public health who's kind of providing more technical expertise to the district level. Right. Let's focus. So we are not going to talk too much about the national level because we are talking about district and below. Let's look at what happens at this sub-district level. So we have this activity, we call it a monthly conference, and it is a data review meeting. No, it is not. It is not about reviewing data. It is about monitoring all the activities. It is about the interventions. So what we try to do in this level, not we, but the MCH system, is that these, you might be, unfortunately you are not really seeing the DHIS2 dashboards here, but they are actually looking at the DHIS2 dashboards. But that is not to review data. It is more about to review the progress of the activities at field level and to make sure that if there are any deficiencies, those are addressed. So the data is used to monitor the activities and the actions are taken. So you have all the field health staff, the district level comes here from sub-district level, and you have other sectors also involved. It could be like the schools, sometimes the police, and all the social health workers, they are also here, so that all the decisions can be taken and activities are done. So this is happening every month in all the sub-districts level. Right, and then we have something called National MCH Review. Even though the word national is there, this happens at district level. So this is one major activity that happens every year, where the national people come to the district and all the sub-district level is also there. So they prepare months in advance so that this meeting is conducted successfully. So what are the kind of data that is reviewed at this district level meeting? Of course, the input data like how many trainings and action plans are conducted, and then you also look at process data, output data, outcome, and the impact. So it's a kind of a conversation between the national level and the district level in the presence of sub-district level, right? So it's a very transparent process, and again, it is not only about data, it is about the MCH activities, right? So how does this digital system benefits it? Now the thing is, all this data that has to be monitored, the Family Health Bureau has designed it in such a way, so we have separate DHIS2 dashboards that are specifically assigned for all these areas. So it's a matter of reviewing 1, 2, 3, 4, like all the different dashboards. And the thing is, because sometimes we have some internet connectivity related challenges, they are supposed to go to the dashboards and take the screenshots, and then there is a PowerPoint template provided, so everyone actually goes through this PowerPoint template. So it's a very transparent process. National level sees everything, including the district level and the sub-district level. So when they come to the meeting, it's a transparent thing. I mean, nobody can, like justify something or even cook up data, because it's a very transparent process where all the parties are seeing what is discussed. Again, some screenshots of the PowerPoint template. And during the pandemic, how were these meetings conducted? Because national level can't go to the district, and sub-district also was to engage. So all these were conducted online. So what you are seeing here is, these activities conducted during the pandemic online. Why? Because the system was in place and the process was in place. Just if only the system was there, process was not there, this would not have been a success. So this was how they conducted these review meetings during the pandemic. Right. I think Pramil mentioned about local community of practice. This is not that. This is a separate one. A community of practice which is there for MCH activities. So this is run in each district by this district champions, and the users are public health midwives and everyone else. So you see like the different things that are shared, including some research articles. Because sometimes the doctors ask and query, why do you say this? So that the district champion has to share with some research, so that doctors are convinced. So, that's always a challenge when you have these multiple stakeholders acting at the same time. Right. So, quickly going through, 8 minutes. Success factors, there are many, right? But I must emphasize governance, right? So, if you imagine, if you want to introduce DHIS2 to a country or a program where the governance is not in place, don't expect DHIS2 to fix your governance issues, right? So get your governance right first, get your process, leadership, everything arranged, and you try to introduce DHIS2. Otherwise, DHIS2 will be showcased as a failure. Why? Because you didn't have the process established. So do a proper planning of your workflow and then introduce DHIS2. Then only you will be able to show success by introducing a digital system. And it's a very local, ownership is local, we are just facilitating, we have no idea what data is there in the DHIS2, but what we make sure is to build capacity at all levels, meaning like these are very localized work that is done. So national level of course is influencing, but the district and sub-district is what is governing this process. Of course, areas for further improvements, while there is a lot of follow-up, there has to be like, we have so many features, right? Interpretations and things like that, which we don't really see that being used to the expected level, because our goals are really high. So that's some area where they can improve, and then of course the supervisions can be improved further while it is at a decent level already. And then the other main task is to go to the individual level, right? So that's some plans. I think Dr. Priyanka is here. I think they are going to plan it probably for 2026. They are going to go for the individual level, so that individual level data will be feeding all these dashboards. Right, 10 minutes, that's up. Yeah, I stop there and then I hand over to Jon.
You forgot to say anything about the methodology.
Yeah.
The important thing when we do a case study is to go out and have a look and see what you find and see if that is up to expectation. And that, as Sam told about Lao case, we also did the same in Sri Lanka. And now I would like to send that ball over to the others. I mean, how do you, for example, I mean, we have heard from Jakarta. Can you go out and tell us exactly what's happened on the ground with your stunting data, dashboards? Are they used in the facilities? That could be a challenge for the presenting next year and even before, to go out and see what's happening on the ground and learn from that. So that was the main target for this HTC data use case study. To go out, see what's happening, come up with a recommendation for improvement, and go on to the next step. And Timor-Leste, same thing, you know, can go out, see what's happening, and feed back to the audience. So that was what just I wanted to say as a final commentary. And we focused on these routine meetings of data use, and to move from only looking at the kind of completeness, etc., to actually use the data, analyze the data, look at trends, and see what can be done. So actually, this idea about focusing on the routine meetings, that's something we learned from Indonesia. The Lokmin meetings in the Puskesmas and in all the health facilities was kind of the template for this approach of focusing on routine meetings for routine health information system usage. So that was my comment. So all the teams should then think about how they can conduct similar case study, whether it's in Nepal, Timor-Leste, Jakarta, or Pakistan, Bhutan, everywhere. Okay, thank you.
Thank you, Professor. One or two questions. We've run a little bit over time. Thanks for moving fast, Pamod. Did we have any questions? I see you grabbed the mic. Oh, up the back. Yeah, do you want to go up to the mic there?
Thank you. My name is Dr. Ababagar from Pakistan. And my question for Lao team. What are the difference between your intervention from one province to another, and one province achieved their targets and another did not?
Okay. Yeah. In case of Laos, so what we identify was with one province we can clearly identify the champion. So meaning the one who can, who knows DHIS2 very well, don't have to depend on the central team or HIPS, that they can support the local people. But in case of in the south, as you know, like to become influenced or very fluent with DHIS2, you need some skill set that we try to, that's missing there, that we are trying to build, and I hope that having one in each province will help that a lot. And that's what we see, that the North, because of that person is helping, also coordinating, being a focal point and taking all the initiative, that's a key success. Yeah. But in our case, I think like Pramod mentioned, in Sri Lanka they have the district champion. In our case, we only, because the size of the country, the only provincial works quite well in our country. Yeah.
Thank you.
Another question? Anand, you had your hand on the mic? No? Make it quick, and then we'll go far.
Not exactly a question, maybe some thoughts from our side. So what's in Bangladesh, what we are trying to do, data quality improvement, the Pramod already mentioned, outlined several issues, and Professor Joran also indicate what's need to be done. But you know, the one component, if someone want to manipulate data, you cannot prevent quite easily. So you can do it on time, but manipulating data, how you prevent that? So best way, what Bangladesh currently doing, we are linking with the trackers. So when it's case-based and all data is incorporated there is some checks and balance. You can automatically improve the quality of data. In Bangladesh, almost 100% we are implemented aggregate system. Now we are moving to the tracker and link the tracker with the aggregate. For example, causes of death. So is the all deaths are reported or not? So how do we check? We check with the register, because every hospital has a death register. So when the case-based register is coming, we compile every day. And so send the data to them, and they check with the register. If doesn't match, they ask them why it's not entered. So though there is one issue, because the legal case, which is go to the police, is not entering in the causes of death because of the legal reason. So except that, the number should match. So that's how we go forward for the trackers. And so Bangladesh is implementing since 2010. It's a long time. But we don't have luxury. You may not have a luxury for 10 years to aggregate, then switch to the tracker. If possible, move to tracker now and make from aggregate from there. This is most ideal way to have the good quality data and try to capture everything. And if you can link tracker data with money, then most ideal is to extract them. So what our urban health we do, we link the tracker with the each service. They have only 10 taka, which is 1 cent. So this link with that, and this link with the bank account. So if doesn't match, means they have some sort of corruption. So that should be audited. So this audit done in every quarter. So if money match the data, then data is automatically corrected, because they have to report the proper number. Every service has a money and subsidy. So subsidy should match the earning, and earning should match the data. Then automatically data will be corrected. Thank you.
Okay, great. Look, we're a little bit over, but it's lunchtime now, which is, I think everyone's been looking forward to. But thank you to all the presenters. We'll make sure everyone's back here by 1:30 and in the room, ready for the last session, which is all further presentations from countries. So yes, we can go for lunch now, but thanks once again.
Cik.
Test. sama. Kok sama? Kayaknya Mas Dimas doang yang nyambung. Coba dulu. Kan Mas Dimasnya juga katanya. Dari scope of work-nya itu benar sudah nggak ada. Terus buat materi doang kan?
Hello? Let's get in for the last session before we close. Okay, let's get in. Okay. Hanan, the floor is yours.
What is the updated? Is there an updated programs here? What is the updated? What is the updated program? Can you ask? Updated program now.
You have the rundown?
The agenda, updated agenda, yeah. I have one, but that's not updated. Updated agenda. Who's country? I saw 4 countries, but now I saw 2 countries. Pakistan. So according to this, okay. So good afternoon, ladies and gentlemen. Hope you enjoy the lunch and don't feel sleepy. Now we have a few important country presentation and from Yemen, Maldives, Bangladesh, and Timor-Leste. So I request you all to take your seat and leave all your devices and concentrate on the presentation. So first I request Yemen to put their country presentation in front of you. Thank you.
Good evening, everyone. My name is Ahmed Saidi. I'm Director General Health Information and Research, Ministry of Health, Yemen. I'm pleased to share Yemen experience in building National Health Information System by using DHIS2. DHIS2 in Yemen, key insight from the National Digital Platform implementation. Outline overview, we'll discuss overview on HIS Yemen, DHIS2 in Yemen, aggregate data system, tracker system, digital health portal, achievement, challenge, future plan, acknowledgement. Overview on national health information context. In Yemen, we have more than 5,000 health facility, referral hospital, general hospital, district hospital, health center, health unit. The current situation in Yemen due to the internal conflict or ongoing country deviation, health information management is administratively split. Aden operates part of the facilities in the south and east under me. Sana'a offers facilities in north and west. However, the digital direction and data collection models remain unified with DHIS2 serving as the common platform for health data standardization and reporting. The strategic direction, the National Health Information System Strategy 2024 to 2028 identify DHIS2 as the national digital platform for aggregating health data. Strategic Subjective 7 establish integrated DHIS2 national instance to unify data and support evidence-based decision making. Overview على digital health under the Ministry of Public Health and Population. The DHIS2 based system, we have health facility statistics system, HMIS, also causes of death registry and first stage, birth and immunization, tracker, NCD surveillance and mental health system, injury and emergency care tracker. Other health information system, non-DHIS2, HIRAMS, health resources, the health resources and service availability monitoring, EDUS, electronic integrated disease early warning system, also أيضا ELMIS, electronic health supply chain management system. This is other platform, يعني custom platform. Other digital platform, صحة digital portal in first stage. We have birth notification and immunization card, صحة e-learning platform for training, telehealth project and telehealth platform. DHIS to aggregate data structure, the mean health program data set, reproductive, maternal, newborn, all reporting, a child and nutrition, the nutrition report, ABI report, MAM, SAM أيضا from nutrition, also community and mobile services هذه أيضا also facility and clinical services يعني what's this problem lab service 1 minute اسمه facility services يعني statistic report lab service report hospital bed movement injuries and accident report blood bank report. Also we have a health facility profile form currently under the implementation in progress. وthis طبعا work on creating unified health facility profile to standardize basic information for public and private facilities. DHIS2 tracker system in Yemen, we have the individual level tracker, severe registry and vital statistic, to encircle vital statistic per registry, non-communicable disease, mental health surveillance, injury and emergency surveillance, but in second phase or in second stage. As enhancing the vital severe registration and vital statistics system through DHIS2, this initiative align with the strategic objective 10, the National Health Information System Strategy, which focus on strengthening severe registration and vital statistics system in Yemen. The work is currently in its first implementation phase and serve the national model for digital integration between health and severe registry system. Birth registry established digital for real-time birth notification and immunization data through DHIS2. Pilot implementation in Al-Mawasat in one district, covering all health facility. After that, we'll expand training to 76 health facility in Al-Mawasat and the Shamaytain district, two districts. civil registry offices granted system access to ensure coordinated birth registration. Recognized for outstanding engagement in digital health transformation for Al Mawasat district. Integration with digital health portal to connect birth registry from DHIS2 with digital health portal, enabling citizen to access official digital record like the birth registry tracker linked with the national digital health portal. A citizen can access digital birth identification and immunization card by this portal. The causes of death, the part 2 from CRVS, the causes of death, with technical support from World Health Organization, WHO, 20 referral hospital were trained on the international class of disease for causes of death certification. The system uses the causes of death app that developed by University of Oslo and HISP Vietnam with implementation support from HISP MENA. The national health data certificate has been digital incorporated into the DHIS2 for the first time. The challenge and proposed solution, the causes of this app depend on good internet connectivity, with is difficult in many areas of Yemen. Most the deaths occur in the community, not in health facility. A community death tracker is proposed using verbal autopsy method with plan to link and harmonize this data with DHIS2 causes of death system. HISP MENA has been approached to technical support to implement this model. Current challenge, generally infrastructure, server issue, system downtime occur when multiple tracker platform. The platform will to aggregate data, but faced stability issue with tracker program to now. Technical and user support, mobile application challenge, limited national technical capacity, also connectivity and hosting, poor internet and connection infrastructure, even also full cloud hosting is not yet sustainable solution due to local connectivity limitation. For financial and governance, donor funding interruption, no dedicated governance budget, some legacy systems still collect data outside the unified DHIS2 structure, but still DHIS2. The key achievement made DHIS2 the national platform of health data under strategic 7 of HIS strategy 2024-2028. Expand DHIS2 to cover all aggregated data, and 7 tracker program, some now in phase 2 implementation and some in phase 1 training. Trained nearly more than 3,000 end user across country, Aden and Sana'a, in DHIS2. Strengthen the central technical team through participation in multiple regional DHIS2 academies, enabled printing of digital birth notification, medical death certificate within the system, launch online user training, and University of course on health information system in progress. Joined multiple global digital health initiative, global digital health partnership, global initiative for digital health, enhancing Yemen presence in digital health community.
I request to go quick because your time is already up.
Okay. The future plan and needs, strengthen and expand capacity of national DHIS2 core team, scale up the DHIS2 platform to reach the health facility level and include community health workers nationwide. Data use through research initiative based on DHIS2 to promote evidence-informed decision making, integrate artificial intelligence and advanced analytics to enhance data interpretation and forecasting, mobilize sustainable funding and bridge existing financial gap to ensure continuity and national ownership. With sincere appreciation to all partners and friends who have supported the development and expansion of the DHIS2 and national health information in Yemen, especially thank to the World Bank, USAID and GSI, JAFI, WHO, UNICEF, UNFPA, HISP Center, and our dedicated partner at HISP MENA. Thank you very much.
Thank you for your nice presentation. As already time is over, so we'll take the question later. Thank you.
Okay.
You may take it. Now I request Dr. Momen Abdullah from Maldives to have your country presentation. Please welcome Dr. Momen Abdullah. Can you turn on the microphone? Turn on the microphone. Yes.
DHIS2 implementation started, our journey started in 2019 with our statistical reporting, that is routine submission of mandatory reports from all the public health facilities and the private health facilities. So that was the beginning. So we collect monthly reports, bed reports, outpatient, inpatients, bed reports, HR reports, and all the other statistical requirements that we need to do the, we collect all those reports through the DHIS2 from 2019 onwards. And then with this experience, we shifted the utilization of DHIS2 tracker in the electronic immunization registry to track the vaccination from birth in 2022. In 2023, we added our primary health care registry, which we just presented before lunch. So focusing on NCD, screening 18 years and above of the whole population. And in 2023, we also implemented our national cancer registry that is used by the tertiary hospitals. And in 2025, we also, from January this year, we extended our EIR program, Immunization Registry program. We added a module for the growth and development milestone monitoring for children below 5 years. So these modules shows that Maldives is using DHIS for both aggregate and tracker data. We also are focusing on strengthening the national health programs and improving our care. And currently, with the capacity of our in-house team, we have also developed these three models, that is for lymphatic filariasis surveillance and aggregate data to see how much the blood donations is taking place within the island facilities. Blood bank report, and also our team has developed an aggregate module for tobacco cessation report. Now these three modules are currently in use, and also our plans for 2025 and onwards are that we are planning to develop the maternal and reproductive health module, second tuberculosis screening, and then we will be focusing on CD module, finally family planning aggregate module. These four areas we would be focusing in future. And when we look at the key success, from the beginning itself, DHIS2 was implemented with involving our key stakeholders. And also from all the key stakeholders, including our programs from health protection agencies and other, and if it is related to environmental, we will be inviting our environment ministry, or if it is including any other programmatic areas, we would be involving all related stakeholders. So that was, I believe, that a major success that DHIS2 is implemented in that way. And also, when we are involving the stakeholders, we focus on how we would be pooling our resources. So from the beginning, we would be including WHO, UNICEF, and UNFPA, and IOM. So that was one area. So for example, even this year, we were working very closely with IOM. In that regard, we were able to pool resources through IOM to develop a migrant module for the Maldives. Number three, then we also adopt a phase-based result approach. We always focused on whether first phase we would be developing a certain modules. So the similar way, this year, these modules would be prioritized, and for the second year, additional modules would be given prioritized. So it was based on a phase-based module. And also, we were very much focusing on our local capacity. So with the Sri Lanka team, we were working very closely to develop our in-house team as well. And the modules are designed to be robust enough to cater to changes easily on user feedback, or if we get any last-minute change requests. And also, lastly, enable citizens to access their health records through our Maldives Integrated Health Information System, MIHS portal, promoting transparency and trust. Now, building on those success factors, another critical piece of our progress is integration across programs and sectors. First, DHIS unifies key public health monitoring programs, enabling streamlined data reporting and creating a longitudinal health record that can track individuals from birth through their interactions with public services. Second, we are focusing on health facility HIMS integration. So that would be our next focus, to work on all the integrations. Third, ongoing digital and national identity system. So we are trying to integrate with national ID also. So all the integration will be focused as a next stage. So wait.
Can you press the slides again, please? Yeah, please.
Yeah, this slide. Okay, now as I discussed before, so this is our Maldives Health Integrated MIHS portal, where the citizens access to their own health records. So through this portal, there's one module, one additional information that the public can access, the electronic immunization records. So all the immunization records will be accessed. The parents, the mothers, the parents, the guardians can access the child's immunization records through this portal, in addition to the non-communicable disease screening data. So one more thing that I want to add, the other question was about how the EFAS, there's the EFAS, the blue login is the EFAS. So that is the National Digital Identity Services backed by the Maldivian government. It allowing the users to create a verified digital ID to access government and the public and the private services. It serves as a secure, unified digital credential that can be used for various services to access government portals. So, similar way, MIHIS portal is also accessed through the EFAS as a credential. So this is how the digital vaccination record can be accessed, can be viewed from the parents, as a parents, how it can be viewed. So, to drive the impact, we focused heavily on cross-sector engagement as I mentioned before. First, under the stakeholder engagements were building strong collaboration beyond the health sector. For example, requirements from the social ministry, the social or gender ministry. So if they have any requirements like capturing the newborns, any additional data, we were trying to capture, fulfill their requirements as well. We also are in discussion with Ministry of Tourism and exploring other ways to capture migrant health data as well. The previously mentioned digital IT integration will be ongoing, and we are also exploring the possibilities of how we can integrate with private hospitals to capture the cancer data. So, and lastly, the local leadership and co-ownership will have central to our approach. This collaborative model will continue to make DHIS2 a sustainable, cross-cutting example for Maldives.
Thank you for nice presentation. So if, as we have some time, so if any of you have a question, please you can ask now. Any hands? No. Okay, that's great. It's a nice question. Thank you. Now, actually, I have to invite my director MIS. Unfortunately, he is not here. So I'll be presenting on behalf of him. So I'm presenting Bangladesh country presentation. So I go with Mike. I already give you from last 2 days, you see lots of presentations. And you also see Bangladesh presentations yesterday and today. So I'll be not repeating all those things. So we'll go to the what's new and what we are new doing. So not repeating and creating your, bit of. Okay. So what's new we are doing is Bangladesh is moving to the digital health strategy. So we already approved digital health strategy. Actually, we do a lot earlier, but the secretary signed actually in 2023. So digital health architecture, an evolving system under Minister of Health. So who will lead the digital health system? That's become a debate. Because in my country, there is a Ministry of ICT, is supposed to be head of all ICT thing. But when it's come to the health informatics, then it's a tricky question. So they said that will done by us, we say that will done by us. So at the finally, this come to the Minister of Health to have the digital health policy and to aim to create an integrated, equitable and sustainable health ecosystem. So sustainable is the very important point. So, sustainable is the important point. So we choose the open source product like DHIS2 is for sustainability. When no one is there, at least people, the capacity development to the ministry so that they can run the system by themselves. So that's the idea. While showing the progress in the key registry, there is a lot of other systems, and DHIS2 is the most used system. So almost 90% of our health data is generated by DHIS2. Though we have a lot of implementation with hospital automation, there's HRIS, so that's I will go. So the key components are, number one is DHIS2. So you all know it's a web-based platform has 3 distinct components: aggregate, event-based, and tracker. So three components, we build almost 90% of the health data of Bangladesh. Second part is the human resource system, or HRIS. This is an open source tech-based system, mainly for health facility provider identification. So it's a provider ID, and this provider ID we use for the all DHIS2 system with as a secure identity provider platform, so that one user don't have to use the multiple username password for multiple systems. They can use the one username password for the same system. So HRIS is as a workforce registry, or the provider registry, also used as a facility registry, because it has all health facilities in Bangladesh, including public, private, and NGOs, and the ID provider for the public health workers. We also have a national call center, which is 16263. So anyone can seek medical attention with this phone number 24 hours a day. So this is a call center. This is also under Ministry of Health. So it can facilitate telemedicine consultation, and they can print prescription and go to the medicine shop and buy the medicine with that prescription. And if it's an emergency requirement, you have to call the 999 number, and from that they can have the ambulance and other emergency service. So we also have separate telemedicine service. This telemedicine service is the on-premises, means each community clinic, they can consult a consultant in the capital city to have a specific patient consultation. So this is doctor to doctor, so from sub-district to national level consultation, or super specialized hospitals, they can have the consultation. So this telemedicine system has a specific device list, so mostly it's the internet operable devices. So the remote devices, remote stethoscope, those kind of thing is also there. So there's some sort of setup required, so we have most sub-district level, we have that. Citizen engagement tools, so we have the complaint and management system and suggestion management system, and the dashboard I show you this morning, we don't have time, so we cannot show you much. So in that dashboard, there is a portal where you make a complaint, it's appear in the dashboard. And dashboard, someone is monitoring from the government side, and what action taken against your complaint, that will be there. So people can monitor their complaints as well. So we facilitate public, general public to access the data and use to improve the citizen service. Those who know what Bangladesh is, so this is one picture. Bangladesh is a very small country, only 55,000 square kilometers, 65,000 square kilometers, 10 times smaller than Norway, but the population is 180 million. So more or less 50 or 100 times more than Norway. Okay? So you see, but that's the problem. Why this is a problem? When there's a lot of people, there's a lot of data. When you go for individual level, you should be very careful about how should you manage your servers. So that is actually, so given division has average 20 million. But if you consider Dhaka city has 35 million. Be careful, 35 million, more than many countries. So this is a picture, give you how dense we are. So key activities, we have 7 instances, not going with this one, because slide view will be there, but this is the major instances, and all major means very major. For example, national health system, this is actually 700 GB database size. You can imagine how big it is. Same as community clinic. So community clinic already have 20 million registered women and children, 20 million. And COVID-19 is less, so 5.5. Cervical cancer, you saw yesterday, this also have 5 million. And for the urban HMIS, this is also quite a lot. You see the dashboard this morning. So I now go to the key achievements. I already told yesterday. So this is the DHIS2 status. All greens are DHIS2. Blue are, or greens are DHIS2 complete 100%, and the others one are using partially. So you see, almost all is using DHIS2, almost. So what we do now? So we should rest. Now, what we are doing, we started with the aggregate. Now we're moving to the event and the tracker. Why? this gives us the most accurate data and timely data. So not waiting for the 7 days for data completion and others. So if you go next, so what we are doing in tracker recently. So we introduced the IMCA tracker. So what is that? You know, the IMCA tracker, there's an assessment, the IMCA guideline of WHO. Following that protocol, we develop an assessment decision support system tools. So when a children there, so that is tablet based, so they can click, and within click, they decide where should the children go, whether that is referred, what to do, or urgent referred to indoor, admitted there, or not. So that is actually they're trying to do. So this is the flow chart. So development started in 2014, currently used by 307 different types of facility and 11,500 visits. Plan to scaling up to 2026 to 28 to the all remaining facilities. So that's also very challenging for program rules, because all decision support is guided by the program rules, and that's quite challenging. We also built a Scanu tracker this year. Scanu tracker is a UNICEF initiative, so special newborn care unit. So registered patient with the ID, as this is a newborn, there is no ID, so we use this mother's ID and make the newborn assessment, newborn treatment, diagnosis and outcome, and the facility follow-up. And after the release, that's go to the community. And that's, we send the data to the open SRP for community follow-up, where there is open SRP. And where there is no open SRP yet, so this is go to the DHIS2, community HIS. So where they actually follow up that specific children, and this follow-up come to the DHIS2 again through the API. So that's actually, we push and pull the data from the DHIS2 and OpenSRP, also DHIS2 one instance to another instance. And this linked with the ID systems, ID name and addresses. So this also has a linkage with the shared health records, which is the national data repository for all patients. So Scanu tracker, the 18 facility currently using the Scanu tracker, 18 facility, and another 16 facility which is starting within this year. So as is need a special newborn care unit, means it has some special facility like say baby, various equipment is required. So government is doing step by step. So all 64 district will be done in first, because most of the super specialized and district hospital has the special newborn care equipment, so this will be done fairly quickly. And also we link with the kangaroo mother care or KMC program. So post neonatal period, we are linking with the KMC tracker as well. So critical alert generation according to the findings of the newborn, automated scheduled for community and facility follow-up. If community follow-up he or she does not show up, this will be SMS go to the health worker as well as the mother to have to follow up them. This also linked with the birth registration. So we send the birth notification to the CRVS system. So birth notification we send from the DHIS2 system for several systems. One is this one, and another one is our hospital inpatient system in DHIS2. So that is also if a mother there is a delivery, we send all child information to the CRVS for the registration. And this is one of the integration of the DHIS2 with CRVS system. So this actually go every night as a batch, because they are requested to send as a batch. So we send all the birth today, we'll send by the night to the all to the CRVS system, national CRVS system. Another tracker we are developed is the AFI surveillance, which is a tracker program. AFI surveillance actually we did in 2019. But there, you know, the AFI has several steps. There's a causality assessment. This part, causality assessment, we introduced this year, jointly with the National IRC Committee, Vaccine Review Committee, IRC Review Committee. So all those we are actually do, and that's from where we are send the data to the VZ base, the Uppsala. So that's update the data from there. There we have some bottleneck because of this portion, actually responsibility of Director General Drug Administration, which is separate unit. And we'll do that, there's still a tug of war. So we are trying to mitigate that. Whoever it is, we design the system, and they can do by themselves. I asked Naim to add few points on this, if you have.
In this area, we, as Hanan Bhai said, we have developed the AFI tracker from 2018 and it has been running since 2019. But the thing is, on that time we have only the case notification, case reporting, and some sort of information of case investigation was there. But now we have developed the full case investigation format according to the WHO and WHO module. And then also the causality assessment with the ERC committee, that is a separate committee from the EPI program. So that is an independent committee to those who are doing the causality assessment. So for all of them, so we developed the things. So now the electronically submission of the case, the case investigation and the final cause to the VG-based and SORA monitoring. So that part we are developing. So it is almost completed, but as Hanan Bhai said, there are some legislative issues between the DGDA Drug Administration and the EPI, because officially the Drug Administration DGDA is the organization to submit the data to the VG base of Uppsala monitoring. So
Thank you.
that part is.
Thank you, Naim. So then final one is the urban health. So urban health, this morning I said you, the urban health is a go under the Minister of Local Government, which is a different ministry. So HIS was hired 3 years ago to fix this issue, because there is a lot of systems, but none of them survived. So they asked something who can sustain. So we built the system, and project already ended last December. Now we have a small extension up to last June. Now project is the end. But this project is still ongoing. That means government is run by themselves. So all city corporation municipalities are run by themselves. As it is in DHIS2, there is not much hassle. Also, that has a monetization, means they all service has a value, and according to value, government gives some money. So they have money is linked, so data quality is excellent. So there is, we have using the DHIS2 tracker for the first time. This is a mini EMR. Initially, we was asked to whether we can build in OpenMRS, but we thought that, look, in this role resource setting for sustainability context, DHIS2 will be the better solution. So we use the DHIS2 and we successfully complete. And ADB, specifically ADB is extremely happy, because for the first time, their intervention in the last long years, 15 years, they are showing some data in various places. So 54 million service was recorded up to the June. So this is the system where ADB directly get their reports from. So thus we are very happy with this implementation, as it can generate the requirement of the World Bank and ADB, and also the World Bank. So this has the one good example where people can generate directly from there, and 102-page reports actually generated from this for the government and ERD. So this is all from myself. Thank you. So now I am requesting, any question? No question? Okay. Then maybe we are too good to present, then everyone understood clearly. So now I request Timur Leste to talk. Timur Leste, Mr. Calistro Pachico. Am I right? Thank you. So request you to present on behalf of Timur Leste. Thank you.
Yes, thank you very much to the time given to me to present in overview implementation DHIS2 in Timor-Leste. Yes, this is a journey or implementation milestone DHIS2 in Timor-Leste. So in 2013, in September, so DHIS2 was recommended by Health Management Information System, named as TLHIS, or Timor-Leste Health Information System. And in 2014, we get approved from the Council of Direction Council of Directors in May 2014, and then we also have a revision for all of the form, for the health management for system in 2014, and in 2015 we customize of health management information system form and implement for the 5 district. And then in 2016, expand to more 3 district. And then in 2017, complete for the 5 municipality to all municipality. And in 2019, we have a national workshop to develop integrated health information system. And then in 2020, we have a revision of national DHIS. And then in 2021, we use DHIS2 for immunization tracker, COVID-19 immunization tracker. And in 2022, we upgrade the version of the DHIS2. And then in 2023, implement for the Asia campaign, and we revise all of the indicators from primary healthcare. And in the last years ago, we have a 23 form. And the base of the indicator from the primary healthcare that revision in 2023, now we upgrade to the 28 forms of program. And in 2024, we have version upgraded to a school health program. It's PV campaign. And in 2025, and in 2024 also, we socialize all of the indicator that revised in 2023 to all of municipality about the definition of the data element, definition of the indicator to all of the municipality. And then 2025 to reporting form update with the dashboard. So this is status implementation DHIS2 in Timor-Leste. So we was implement DHIS2 in 14 municipality. So data entry is mostly done at CSA level, dedicated by our HMS dedicated there, and continuous refresher training provided to users, and then managed by the system managed by the health management system. And then with support with WHO and HIS support. And then mainly focus on primary health care, care setting at CSC. As you know that our DHIS2 now implement base of the primary health care in the CSC and then help us. So the programs are immunization, nutrition, and as I mentioned that in last we have a 23 program, now based off the indicator that we revised in 2022, now we upgrade to 28 form. And then communicate with disease surveillance, outpatient care, and others. So this is flow data that we have. So the data collection coming from HealthPost, CISCA or outreach mobile clinic comes through CSC, clinic, community health center, and then community health center goes through to the district, and then district comes through to the national, to the HMS department, and then we also have a report from the secondary healthcare and then tertiary, like a regional hospital and a referral hospital and national hospital. They report through to the national direction for the hospitaler. And then the national hospital, they analyze all of the data from the regional hospital and referral hospital. And then provide as the key indicator that HMS need as currently now they report 6 indicator like SBOR, LAW, ZDR, NDL, SADET. And we also have integrated case-based surveillance for Timor-Leste. We call ICBSTR. Yes, in integrated case-based surveillance for TB, malaria, and HIV. So we also have an integration strategy to avoid the fragmented of health information system. We started to integrate different disease program, and we also use a mobile application for data entry. This is a data visualizer with ICBSTL dashboard. Yes, this is a custom of mobile application. So this is the documentation of training that we has received all municipality in Timor-Leste with training covered around 1,300 health participants. And in that training also we provide the technical how they can analyze the data. So this is the integration, I think you know, from ICBSTL as a aggregate, as a individual data, and integrate to the DHIS2 is an aggregate. So data automatically if registered in the individual automatically will push to the DHIS2. This is our achievement. As you see, in 2023, we established of DHIS2 instance and integration with a parallel system, and then creation of dashboard to visualize national indicator and custom login page, and incorporate of line list, and how to generate a report to ICBSTL, and integration of parallel information system to single integrated platform, and then develop of mobile application with all the capability of offline data entry and launching of ICBSTL. And in 2024, what we did is design and development of lymphatic filariasis electronic surveillance system and integrate into ICBSTL, and then design and development and success in implementation of DHIS2 tracker for bidirectional screening and co-infection screening, and then implementation of LF validation survey using ICBSTL, and then design and development of dengue, leprosy, and rabies tracker, and conducting national weights training to educate and provide data entry training to all municipality. And then again, we have a capacity building of data DHIS2, operational of health management information system officer at all of municipality. And then what we do in 2025 is national ownership of ICBSTL, and then better outbreak detection and response capacity with more active users. So the key planned activity is metadata maintenance, specifically is unnecessary data element. So strengthening data quality and data use with dashboard and analysis report facet. Transition of ICD-11 of medical certificates of data or MCCD, apps installation, TLHIS, and version upgrade. And we also have a different kind of capacity building session DHIS2 tracker and data analysis for program data focal person and servers training, and then indicator review and data review. For the DHIS2 tracker, data analysis and data quality and service training will happen soon in next month. We hope that Dr. Pamut with other colleagues will come into Timor-Leste to train. I think this is our presentation. So the last, we grateful and thanks to HIPS Sri Lanka and then HIPS India for overview implementation DHIS2 in Timor-Leste. Thank you.
Thank you, Mr. Calistro. Thank you for your nice presentation. So is there any question from our respected guest side? No question? Okay, thank you. So, you see all 4 presentation. If you have any questions on this, please communicate with our all HIS team and the country presentation done by the all presenter. So I thank you everyone and conclude this session. Thank you.
Okay, so good afternoon, everyone. Can I hear some applause from you? Yeah, so we are approaching the end of our conference, of our discussion, and all of our meetings. We really hope that we have like some fun time together and also great discussion all together. Now we are going to have again. We opened the session with a Mentimeter, if you remember, and then we are going to close this with another Mentimeter as well. So I'm going to be, so my name is Richard, in case we haven't met before, and I have my friends.
Yes, thank you, Richard. Yeah. Okay, guys, we will, okay, yeah, for joining the Mentimeter, you can go to menti.com and then enter the code 7921 6559.
In case you prefer a mobile device or any device with a camera, you can scan the QR code if that suits you better. Just in case you have any trouble in connecting with the Mentimeter, please raise your hand so our friends can help you to join the Mentimeter. Thumbs up.
Not yet. It's 34.
While you guys are preparing the Mentimeter, I want to inform you that all the presentation materials are going to be emailed right to your email for your registration when you register. So make sure that the email that you registered is active, and we can send an email to that email. Just in case you prefer or you prefer another email, or your current email is not working, please reach out to the organizing committee so we can help you with registering your email. So.
Have you into the Mentimeter? It's been 73. It's 37.
Anyone having any trouble? You can raise your hand. 1, 2, 3. No? Okay.
Okay, let's start the Mentimeter.
Okay, so. Oh, people are already answering.
Oh, okay.
So, Do you agree that this conference met your expectation? So we have mostly yes, fully. So I guess big round of applause for everyone, for all of 17, 19, 20. Okay, yes, fully, someone.
One more.
Very happy to see that no one is answering for no, not at all. At least the tea is nice.
Okay. Next.
Next question. Okay. I was satisfied with the organization of the conference, whether it's registration, assistance in hotel booking, and etc. So, more on focusing on the your convenience, the administration sides. Everything's happy. Everyone's happy.
Yes. We wait for 2 more people. I think it's good, right? Yeah, 2 more people.
Next question. I was satisfied with the conference venue. So, 29 people answered yes fully. We're waiting for one other person. Yeah. In majority, please have a round of applause. Thank you so much for Discovery Kuta Hotel for being such a great venue. Next question is, do you agree with, I was satisfied with the quality of the content within the conference. Do you like the materials? Do you find yourself enjoying the discussion? 2 more people. We are waiting 1 more.
Oh, I think it's a lot of people agree, and yes, fully. It's 23. Give applause.
Next question. The facilitators were able to assist me in answering my additional questions. Everyone agrees, no one disagrees. It's just so yeah, 2 other people, but I think we can see that everyone either agree or strongly agree. Good job, all facilitators. Next, I was satisfied with the time and pace of the conference. Everyone in majority strongly agree. We are waiting for 3 more people.
Okay. Next, maybe. Now, achieve my goals in attending this conference. I think, yes, there is no disagree, right? Here.
If you disagree, it's totally fine. You're completely anonymous. But you can always answer what you feel. Okay, I guess 3 more people, but I guess we're good. Next.
Oh, I think almost all of people here want to come back to this conference again next year.
Zero no. 7 unsure.
7 unsure, but 33 yes.
33 yes.
Okay.
33 says, I'm going to come back. Whatever happens, I'm going to come back. Okay.
Okay, maybe next. I would recommend this conference to my colleagues and peers. So I think everyone say yes, but one answers here.
Okay. What was your favorite session within the conference? You have so many answers, country presentations.
Gala
Second is
dinner,
gala
I
dinner.
think.
Nice. No one's saying the dancing in gala dinner. Okay, so we can see the clusters, gala dinner, fire, country presentations,
Climate.
So
I
gala
think,
dinner
yeah.
is the biggest now.
Everyone loves gala dinner
Everyone
here.
loves gala dinner. So yeah, we can see 5 more people. We're going to wait for 5 more people. 5 more gala dinners. Okay, next.
Okay. And what topics would you like to see more of the next conference? I think here, data quality tool, data equality, data visualizer, success stories.
All. Okay, nice.
Okay, nice.
AI. So yeah, it revolves around climate, data quality and equity, also implementation, climate health and sustainability, and also a lot of people says integration and interoperability. So many things. Big data session. Okay.
We're going next. I feel the following improvement would improve my conference experience. We can see food.
Food, okay.
5 days.
More Balini sambal for the food. Agenda and materials in advance. Okay. Better assist in hotel booking for international conference in one country. Okay.
Better internet.
Better internet. Okay.
Okay.
Food everywhere. Food variation.
Yeah, I think food variation, food. A lot of food here. 5 days.
Okay.
Okay.
Still 25 out of 42. This one, people takes more time on this one.
Yeah.
I think everyone's like scared. Should I say? Breakout groups include hotel. Okay, new use cases. To the other 17, it's okay. You can be honest with us. Okay, 17 are shy. Hands-on experience. Okay. Yeah. Thank you so much for all of your feedbacks. We really appreciate it. Yeah. Thank you so much for the feedback. Everything we're going to keep this. It's very okay. Any kind of feedbacks are very welcomed. And then we are happy to host you in Bali, and we hope we can see you again.
Yeah. Thank you so much, everyone.
Thank you. Dua? Thank you so much for the almost 3 days conference. But I want to introduce the teams here. Thanks for the many countries such as like Middle East and also Southeast Asia and Timor-Leste from our neighborhood. The next sessions is very important for us. How to conduct the next conference in where? Is any suggestions? No? India, Bangladesh, or Vietnam? In Bali? No. Again, no. Maybe later. Laos?
Bhutan? Ooh! Okay, for the next year, I inform for visiting Sri Lanka. Okay, 2026. I hope the conference date will be 5 days, 3 days, including field trip, and another comment for us, and also we can improve for the next conference. Okay. Next, I think this is the closing mark. I invite you. Oh, Yon Bra and Christine, come here. This is yours. Mark.
This is the
Closing.
closing.
Yes. You have to in the middle.
Yeah, it's an honor to be last in both badminton and in the conference. So next year we will do some exercise in Norway on badminton and speed up the backhand, which is extremely weak, and then we will improve. So that was one thing, and another thing is that I think it was a very good conference, thinking about also that there less funding from all these international donors, etc. And despite of that, it was many countries here, and that was a very good thing. And yeah, I assume that we will be able to do the same at least next year in Gaul or something more interesting that in the city of Colombo, some place in the mountains or on the beach. Okay, thank you. There's some plans for tennis and table tennis and swimming and different things, and that will be after this closure. So let me hand over to Kristin then. Yeah.
The sister. Thank you. As I mentioned in the opening, this is my first ever attendance to DHIS2 Asia Pacific conference, and I'm very pleased to see all the country stories, all the activities. Again, like Jörn said, also all the country delegations. In spite of difficult times when finding finance. And when Jörn said at least next year, I think this is actually, hopefully, and I really think that with a bit of a planning and smartness, we should be able to mobilize funds so countries can come together and share experiences. I really enjoyed the country stories, and there's always room for improvement. Maybe next time also put up the struggles, and maybe we should have some side session helping with the struggles, maybe be more hands-on. I don't know whether we could really work harder on the thing that the HIS network is so good at, to help each other, to be a community that I can actually, but I've seen it happening, learning from inspirations from other innovations that you can bring back home, that you can also get some contacts that can help you when you are stuck in some struggles with some technical matters, or maybe policy matters also. So I really enjoyed being here for 3 days. I think 5 would be too much. I can just tell you, back in the days in academies, when we had the regional academies, it was 10 days, you know, and we won't recommend it, but now it's 5 days or less, yeah. So I'm thinking 3 days is perfect, and this beautiful place, coming to Bali and being able to be here with this wonderful organization, smoothly organized. Thank you, Rati, team, Taufik, HISP Indonesia, yay! You did well. No one was stuck in the airport with no visas and anything. That's a good sign. We know, because we are on our way to Addis and we don't have the visa, and we will start on Monday. We'll see who's we're able to enter the country. So visa is important. Hopefully Sri Lanka is an easy visa country, so people won't have problems going across Asia from country to country. So thank you. I think the next on the program is sport activities. And as Jørn said, actually, honestly, last time I played badminton, I think I was 7. So yes, we will rehearse for next time. So see you in Sri Lanka. Oh, there is a tea break. Of course, always.
Recording stopped.